Good morning, everyone. Thank you so much for joining our quarterly education series, which is sponsored by the NICER Consortium. Today, we have a wonderful topic on Shwachman-Diamond syndrome and have three amazing speakers who are going to speak about all of the new things and old things in Shwachman-Diamond syndrome and neutropenia. My name is Jim Connelly, and I have the pleasure of moderating this session with Dr. Jamie Loutfy. We have a packed schedule this morning, so I'm going to quickly review that before jumping into our first speaker. Our first session is going to be Dr. Julie Warren, and the title of her talk is Approach to Neutropenia, Diagnosis and Management. This will be followed by our second talk by Dr. George Zacur, who will be discussing pancreatic labs and imaging and Shwachman-Diamond syndrome. This will be followed by a 15-minute break, and then we will transition into our third talk by Dr. Kasiani Myers, and she will be discussing malignant transformation and Shwachman-Diamond syndrome. This will again be followed by a 15-minute break. And then the last portion of our session will be a live fireside chat, which is a question and answer session with all of our speakers. With the schedule reviewed, I'm going to go and introduce our first speaker. So it is my great pleasure to introduce my friend and colleague, Dr. Julia Warren. Dr. Warren is an expert in neutrophil disorders and is a physician scientist focusing on bone marrow failure and neutrophil disorder at the Children's Hospital of Philadelphia. Her lab focuses on the molecular etiologies of dysfunctional hematopoiesis with a particular focus on myelopoiesis and development of neutropenia. Before her position at CHOP, she received her medical degree and PhD in immunology at Washington University in St. Louis. She continued her training as a pediatric resident and pediatric hematology and oncology fellow at WashU, where she completed her postdoctoral research. Dr. Warren has won numerous awards for her research and is a scientific leader in the field of neutrophil disorders. When I was putting together all these great accomplishments for this introduction for Dr. Warren, I also discovered an interview where she was asked what her superpower would be, and she stated that either she would make it so she wouldn't have to spend any time sleeping, or she would have the power to measure a neutrophil count just by looking at a patient so kids do not have to be poked so much. So clearly, Dr. Warren is a very dedicated and hard worker in this area, and most importantly, she's a lover of children and taking care of them. So Dr. Warren will be presenting our first session of the NICER Educational Camp. The title of her talk is Approach to Neutropenia, Diagnosis and Management. And now I'll pass this over to Dr. Warren.
I want to thank the organizers for inviting me to come and speak about a favorite topic of mine, neutropenia. We're going to speak in the next 30 minutes, some very broad strokes about how I like to approach neutropenia from a standpoint of diagnosis and from management. And then after me, you're going to hear from some experts, focus a little more on Shwachman-Diamond syndrome. And these are my disclosures, and I'm not going to be speaking about anything relevant to these today. So here's our objectives, reviewing the basics of granulocyte formation, some definitions, some diagnoses, and then we're going to use some cases to talk through diagnostic approaches and treatment. So steady state granulopoiesis refers to the process by which we form granulocytes, and today we're going to be speaking specifically about neutrophils. This process occurs in the bone marrow, starting with the hematopoietic stem and progenitor cells, and then through this orderly maturation of cells that have committed to becoming neutrophils. Throughout this process, we can kind of break these parts of the process down into cells that are still premitotic. So those would be those here on the left-hand side. Premitotic meaning these cells are still capable of undergoing divisions. And we think this process of going from a hematopoietic stem cell to around the myelocyte stage takes about 6 to 7 days. And then the cells over here on the right-hand side are our post-mitotic pool. So metas and neutrophils, mature neutrophils, and those are really going to be our functional cells here. And the formation of these cells takes about 7 days, and these cells are no longer capable of divisions. So when we think about the mature neutrophil pool that's in our body, it can be a little bit misleading when we measure CBC because about 75 to 85% of our mature neutrophils are in the bone marrow at the ready to go when they're needed. About 5 to 15% are already out in the tissue, and really only 10% are in the circulation at any given time, even though this is what we're measuring when we measure a CBC. And I bring up this steady state pool location because which of these pools is being impacted by a disease process may influence the risk of serious infection in that disease process. And so just to highlight this further, let's say we have a process where marrow production of neutrophils is impacted. And so we really have a low marrow reserve, low numbers of circulating neutrophils, but we also have very few neutrophils out in the tissue. So you can imagine that this may be a scenario that places somebody at a higher risk for infection. And I like to describe this as a scenario with an absent mobilizable pool. Some people may say low marrow reserve. This would be as opposed to a process where maybe there's peripheral destruction or something else causing a shortened half-life of cells that have left the marrow. The cells are there in the marrow or in other reserves. They are ready to go, ready to be mobilized. They can make it out into the tissue. Just the small fraction we can measure out in the peripheral blood is reduced. And you can imagine that this scenario really may represent one where there's an intact mobilizable pool and there may be a lower risk for infection. Okay, so we're talking about neutropenia today. We should just go through some brief definitions. So adult normal neutrophil ranges are around 1,500 as a lower limit of normal. Some systems will use 2,000. Many use 1,500, with mild neutropenia as 1,000 to 1,500, moderate as 500 up to 1,000, and severe neutropenia as an ANC, absolute neutrophil count, under 500. We are going to just touch briefly about Duffy null. And then also important to call out that in the neonatal and infant ages, there are different definitions, different ranges. And so in the first week of life, we actually expect term neonates to have ANCs above 3,000. This is especially true in the first 72 hours. That then starts to decline after 72 hours, and by a week and up through a year of age, that lower limit of ANC is more like 900 to 1,100. Preterm and low birth weight, so here we're talking about less than 36 weeks estimated gestational age and 2,500 grams of birth weight or both, use different reference ranges. And those are reference ranges you can look up for your interest, but just to know that they are lower ANCs in those age ranges and in those birth weights. There are some special considerations that I just want to touch on here and we won't keep talking about further. So in that neonatal period, we know gestational hypertension can be a major cause of neutropenia in an otherwise well neonate. And we see that in about 25 to 50% of neonates born to mothers with gestational hypertension. We believe that this lasts for about 1 to 30 days. It's a pretty wide range, but we really don't expect this to persist beyond about a month. And then, of course, in that neonatal period, we're considering sepsis or infection. Neonatal alloimmune neutropenia, which really is an analogous entity to NAIT, people may be more familiar with. In neonatal alloimmune neutropenia, mom makes antibodies against a paternally derived antigen, and those IgG antibodies can cross the placenta into the baby's bloodstream. We do also expect this to be a process that resolves within 3 to 6 months. Congenital CMV can also cause neutropenia even in the absence of valganciclovir treatment. This is estimated to occur in about 25% of congenital CMV cases. And then, of course, we consider congenital or cyclic neutropenia, especially noting that if the ANC is 1,000 to 3,000 in that first few days of life, that is low. And so let's not disregard that ANC, even though it may appear to you to be within a range you would consider normal for the rest of the first year of life. Duffy null-associated neutrophil count is another entity that I would kind of call out as a special consideration. And this is just recognizing that patients or people who have FYA negative, FYB negative serologies can have a lower circulating normal ANC value. This is really well demonstrated here in the study that was otherwise well patients presenting for outpatient care who were either Duffy non-null on the left, Duffy null on the right. And you can see that Duffy null patients, the lowest interquartile range really is below what this health system used as their lower limit of normal. And what's very important here is this is not a disease. It is not associated with increased risk of infection. And so we really shouldn't label these patients as having quote unquote neutropenia. Unfortunately, we don't right now have an ICD-10 code for Duffy null associated neutrophil count. So very often we're still charting that way, trying to make it really clear in our documentation. We don't think that this is a disease state and in our discussion with our patients. Would also just mention that we don't really have great reference ranges yet for patients under the age of 3 who are Duffy null, and that is a work in progress. Okay, so next moving on, I wanted to outline the conceptual framework that I use when I'm approaching a patient with neutropenia. And so I really like to ask myself, do I think that this disease entity has an absent postmitotic pool or an intact postmitotic pool? We kind of walked through that a few slides ago. And is this process transient or is it non-transient? And just calling out that even a non-transient process may still have an intermittent neutropenia. All right, so dividing this into this four quadrants, what I would place here in this upper left would be entities such as infection-related suppression, some infections, myelosuppressive chemotherapy would be an obvious one, and some nutritional deficiencies that lead to an absence of produced mature neutrophils. This would be as opposed to non-transient processes such as cyclic neutropenia, severe congenital neutropenia, other marrow failure disorders, X-linked hyper IgM or CD40L deficiency, and MDS. And when we come back up to the upper right, so here the postmitotic pool is intact. That would be things like immune neutropenia of childhood, which we expect to resolve within 1 to 5 years, 95 to 99% of the time. So that's a transient process. And then neonatal alloimmune neutropenia, which we talked about a few slides ago. This would be as opposed to maybe non-transient processes where you still have an intact pool. So this would be things like primary immune dysregulation disorders, inborn errors of immunity, or things like ALPS, or other autoimmune diseases, for example, lupus. And then I put drug-induced here, and we would expect that to be transient. You withdraw the drug and your neutrophil count should recover. But depending on the exact drug that's the offending agent, that may impact the neutrophil pool really at the level of production here or in a shortened lifespan setting here. And we don't really have time today to go through all of the drugs, but happy to discuss further or answer questions. All right, and then the last thing I want to call out in this framework is that I did put severe congenital neutropenia here under having an absent postmitotic pool in a non-transient category. Severe congenital neutropenia, depending on who's kind of lumping or splitting these diseases together, is really a heterogeneous set of diseases caused by now over 20 different genes that have been described. Some people would include Shwachman diamond under here. Some would kind of pull out Shwachman diamond as its own entity. But I did want to just highlight a few genotypes where we might say there's sort of an intact-ish postmitotic pool. And this would be things like WHIM syndrome caused by gain-of-function CXCR4 variants, CXCR2 loss-of-function neutropenia, which some people are calling that and others are calling a WHIM-like syndrome, and other specific genotypes of SCN, where we really think the maturation arrest that we see classically, for example, in a lane mutated SCN, we really don't see that as consistently, or we may not really see that at all in some of these entities, despite the fact that we would perhaps categorize them as SCN forms. Okay, so of course, you're approaching a patient with neutropenia. You're always going to take a careful history and physical, but there are a few elements that I like to make sure I always include. And so this would be things like the chronicity and the age of onset. Associated signs and symptoms. I like to specifically ask about this list of infections: sinusitis, otitis, pneumonia, abscess, and bacteremia history. In kiddos who are still diapered, I like to ask, are they having or do they have a history of difficult to treat diaper rash? Because this may actually represent a folliculitis. And then always ask if there's a history of colitis in the neonatal period. We ask also about oral ulcers, gum swelling, abdominal pain, impacts of symptoms on oral intake, changes in the stool pattern, and asking questions that are aimed at getting at other signs of autoimmune disorders like rashes, joint pain or swelling, fatigue, etc. We always take a careful family history. We were just calling out some diseases that can be all forms of inheritance patterns: X-linked, autosomal recessive, and autosomal dominant. So very important to take a careful family history. And then asking about the pattern of symptoms. Are they all the time? Are they intermittent? And any medication changes, including infusion medications like IVIG and rituximab. And then when it comes to your exam, of course, a careful physical exam is always important, but make sure you pay special attention to the height and weight for age. Look at that growth curve. Ask about issues with linear and weight acquisition. Oral cavity exam, really critical here, paying attention to the palate, the buccal mucosa, and the appearance of the gingiva. You want to do a chest exam as well. And this is, for example, we can see things like pectus carinatum observed in Shwachman diamond syndrome patients. Careful skin exam, especially in younger kids with attention to the buttock area. Careful spleen exam. And then I always like to look at everybody's nails because we can see some abnormalities in certain disorders like in dyskeratosis congenita or in poikilodermia neutropenia syndrome. So we're going to go through some cases. We're going to start with one case and then do some variations on a theme, talk a little bit about diagnosis and management along the way. So here's our first case. We have a 12-month-old who's presenting for evaluation of severe neutropenia. This was detected at a routine well visit. They also had a mild viral upper respiratory infection at the same time. The ANC was 200. The pediatrician appropriately checked it 4 weeks later when the kiddo was well, and the ANC at that time was 150. Otherwise, normal white cell count, normal hemoglobin and platelets. Kiddo has been growing normally and developing normally, not having oral symptoms, not having diarrhea. There's no family history that's relevant, and the infectious history is pretty benign. One episode of acute otitis media, it did respond well to oral antibiotics, and there were no complications. During this episode, the ANC was measured and it went up to 2,900, but on repeat 4 weeks later had decreased again to 200. And there's no other significant infectious history. At your visit, the ANC is 0, but the exam is totally normal, including your careful oral exam, and there are currently no symptoms. So your diagnosis here is most likely immune neutropenia of childhood. And I say that because this kiddo has a reassuring history and exam. They're asymptomatic despite having an ANC of 0, and they had this excellent rise in their ANC during an infectious stressor. That would argue that the bone marrow reserve is intact in this kiddo, and that neutrophils can get out to the tissues where they're needed, but that perhaps due to a peripheral destruction process, the amount that you're able to measure in the circulation is apparently low and really not reflective of the total body neutrophil stores. So at this stage, I'm often asked, well, is there any utility to additional testing? I do like to call out that anti-neutrophil antibody testing does have low sensitivity and low specificity. In fact, we can see this test be positive across several cohorts. This has been identified in congenital neutropenia patients with defined genetic lesions. So we have to proceed with caution when interpreting this. And then in addition, from an Italian cohort study, they showed that children who have negative anti-neutrophil antibody testing, but a typical medical history like this case, have essentially identical clinical courses to kids with positive tests. So you can always ask yourself, well, if I order this test, even if it's positive versus negative, will I change my management and will I counsel this family any differently? We also are asked, does this kid need to follow fever precautions, which may mean different things at your institution, but may look something like needing to go to the emergency room within 30 to 60 minutes of a fever, have laboratory evaluations with or without a blood culture, with or without empiric antibiotics. So really a heavy ask from families. There's multiple approaches to this. There's really not a solid agreement here. Some providers would say, and I think would be very reasonable here, that you've already seen that this kiddo has an appropriate rise in their ANC with infectious stress and has an incredibly reassuring history. You may not need to impose fever precautions for this family. Multiple retrospective cohort studies would support this approach. Some providers like to see this documented, so may provide fever precautions for the family until they can document an ANC rise. And some providers may reach for this steroid mobilization test, which I'll describe on the next page, to help them feel reassured that there's a marrow reserve. And then, of course, we're always asked, is it okay to vaccinate? And the answer would be yes. And it's important to include this in your documentation to help guide the family and their pediatrician. As far as follow-up, again, I think there's a lot of variability here. So we would expect this disease to resolve within 1 to 5 years, 95 to 99% of the time. And so you might ask, if this kid's already shown that they can respond to an infection and you're not going to impose fever precautions, you're going to vaccinate, you really aren't going to treat this kid too differently than an otherwise healthy kid. Do you need to keep monitoring CBCs? Do you need to keep having follow-ups? Here's where I really like to work with the families and kind of a shared decision-making model. If some families will tell me, look, if you tell me my kid's fine and they're going to grow out of this, I don't need to keep poking them. And I can call you if I have any concerns or if different symptoms arise in the future. Some families, it's very difficult to know that this disease may still be going on and not know if it's resolved, yes or no. And I like to work with families in that setting and come up with a reasonable monitoring approach, maybe something like every 6 to 12 months CBC and maybe annual visits to kind of check in and see how kids are doing. Okay, and I mentioned doing a steroid mobilization challenge. And so, how this test works is that acute steroid administration causes mature neutrophils to demarginate from the marrow and other reservoirs. So, of course, you would only be performing this test if there are no other cytopenias. The exam is normal, especially there's no hepatosplenomegaly. There are no other signs or symptoms that are red flags for you, like weight loss, bony pain, fevers, night sweats. In this test, you obtain a pre-dose CBC with differential, then you administer 1 to 2 mg per kilo prednisone or prednisolone, and then you obtain a repeat CBC 4 to 6 hours later. This test we would consider positive, or they have a response if there's at least a doubling of the ANC in this time frame. And then if you see that, you could manage this as immune neutropenia. Just a few practical tips if you've never done this steroid mobilization test before and you want to give it a try for a family. I always like to prescribe 2 doses worth of steroid. It does not taste good if you're doing prednisolone, and kids may spit it out. So the last thing you want is a frantic call from a family that they already have their pre-dose CBC drawn, but they don't have a backup dose of steroids. That pre-dose CBC should be within an hour of the steroid dose, and the post-dose CBC should be no sooner than 4 hours and no later than 6 hours. All right, so let's do a variation on this theme. It's just a reminder of our first case, this 12-month-old who has a really reassuring history, really reassuring exam, no family history, and an ANC of 0, so most likely has immune neutropenia. We could breeze through this case pretty quickly, but if we make this instead a 12-year-old who also has some mild leukopenia and having some other symptoms such as intermittent oral ulcers, a discoid rash that appeared about a year ago and has been labeled as eczema, but really doesn't have a childhood history of eczema, and is also having fatigue and muscle aches. Again, reassuring infectious history, and then your exam is just notable for the skin findings described and a palatal ulcer. There's no hepatosplenomegaly. I think many people will be clued in at this point that you are worried about a broader underlying autoimmune disease here. So if you're meeting a kiddo like this, you really may consider expanding your initial laboratory evaluations. And this is going to be based on symptoms and history, of course, but may include tests like CMP, complement studies, inflammatory markers, possibly consideration for antiphospholipid antibodies, urine protein creatinine, and then considering sending an ANA, however, acknowledging that something like 10% of teenagers who are otherwise asymptomatic may have a positive ANA. For this patient, of course, with this constellation of leukopenia, oral ulcers, and possibly discoid cutaneous lupus, you are very concerned about SLE. This age of onset really is not typical for what we might call immune neutropenia of childhood, or some people call benign neutropenia of childhood. And so here, laboratory screening can really help you direct this patient to rheumatology if that is the next most appropriate place for them to go. All right, now let's take this same original case, again, that 12-month-old with likely immune neutropenia. And what if instead of being totally asymptomatic, we say that this kid is doing well, is growing and developing normally, not having other symptoms except for occasional oral ulcers that do appear to be painful to the kid because they're mildly interfering with eating. And sometimes the family feels that their kid has a little bit lower energy, but they say it's hard to know, he's otherwise a playful kid. In addition to the episode of otitis, as from our original case, now they've actually had 2 episodes, still pretty reasonable for a 12-month-old, but they also had an episode of community-acquired pneumonia. They were overall well appearing during this episode and didn't have any other symptoms at that time, so CBC was not obtained. It was treated with outpatient antibiotics, which this kiddo responded to very well. No, they're serious infections. And then at your visit, the ANC is 200. The exam is otherwise normal except for there are oral ulcers. So you have this kid in your mind, and then let's make one more adjustment. So let's say this kiddo's meeting their developmental milestones, but their weight acquisition is plateauing. And in addition, they're having these ER visits for fevers that do seem to coincide with significant oral ulcers that also appear painful. And the family is concerned about gum swelling. They haven't been to the dentist yet, though. These oral ulcers and maybe this pain does seem to interfere with eating, but really lasts for pretty discreetly 4 to 5 days. And the family tells you they almost feel like they can predict when the next episode is going to happen, like they can set their watch by it. Again, here's this same infectious history, 2 episodes of otitis and 1 of pneumonia. And again, the ANC is 200, your exam is reassuring except for oral ulcers. So here in these 2 cases, I hope you can see through this spectrum of presentation, you really may be considering a diagnosis of cyclic neutropenia, which we'll talk about, versus this could be immune neutropenia, but with oral manifestations, with or without some infectious manifestations as well. So, cyclic neutropenia is a really fascinating disease. We think about 95% of the time it's caused by variants in a lane. This is characterized by these 21 to 35-day long cycles where the ANC can nadir to as low as 0, and that nadir can last for somewhere around 3 to 7 days. This is, of course, what you would find if you open the textbook. Symptoms really are restricted to the period of that ANC nadir. And then very interestingly, during periods of neutrophil nadir, so that's shown in this teal color here, there's a reciprocal monocytosis shown in this green. And so when the ANC is very low, the absolute monocyte count is actually high. When the ANC normalizes, that monocyte count returns to a more normal level. And you can see this cyclicity to these laboratory values. If you zoom out and look at the total white blood cell count, that often also displays a cycling pattern. Sometimes, but not always, these kids will also have an elevated eosinophil count. And if you marrow during periods of ANC nadir, you will see maturation arrest, just like the severe congenital neutropenia forms of Elaine. To diagnose cyclic neutropenia, unfortunately, you really do need to obtain CBCs 2 to 3 times a week for 6 to 8 weeks. And this is to ensure that you don't miss a longer cycling pattern. I would recommend for the kiddos who are presented in these cases to really consider genetic testing and to do a panel that may include both causes of congenital neutropenia, cyclic neutropenia, but also immune dysregulation genes, and to start working on getting that testing done as you're considering whether or not this child would warrant 2 to 3 times a week CBCs. It's also important to call out that immune neutropenia can have what some people will describe as a cycling pattern. So where this ANC may fluctuate, may go up and down, may have periods being closer to normal. It's important to say that this is not the same as cyclic neutropenia. All right, and then what do you do? Should you treat these kids? So I think really at the end of the day, even if your testing is consistent with immune neutropenia, you really should consider treatment with GCSF because the kiddos presented here really are having significant, especially oral symptom burden. All right, and then lastly, if we take this original case, this 12-month-old who has a pretty benign history and is asymptomatic, and instead we make them a 2-month-old who's here in the hospital, you're seeing them for an inpatient consult during hospitalization for a bilateral periorbital cellulitis. The ANC was 0 when they came in. Despite having this infection, it remains between 0 to 80. Otherwise, the white cell count is normal, the hemoglobin is normal, the platelets are normal. Kiddo has been growing and developing for this short period of time, but does have intermittent diarrhea. Though the family again says it's a little hard to say because it's a breastfed baby, but they feel like the stools are very watery. There's no relevant family history, and the infectious history is notable for umpholitis in that neonatal period. It did fail an attempt at topical treatment and required oral antibiotics. At your visit, the ANC is 0. You're concerned that there may be gum swelling, and they also appear to have some buttock folliculitis. So hopefully here you would be thinking about severe congenital neutropenia. Of course, you may also be meeting this infant with cyclic neutropenia during a nadir. It's important to note that neonatal cycling patterns may be unpredictable. And so this kind of, I told you like every 21 to 35 days, lasting for 3 to 7 days of nadir, that may not be the case in the neonatal period and actually in the first few years of life. For this child, hopefully you're already initiating GCSF therapy. They have a significant infection and they have an ANC that's very severely low. I would also say you probably don't want to wait to work on outpatient GCSF authorization, which can be challenging. Given that this kiddo has already had a severe infection, you may consider sending them home on GCSF. And I would also say this would be a good case to send genetic testing as soon as possible. And again, you may want to send panel-based testing rather than single gene testing, given that we now know there are a wide number of genes that do cause congenital neutropenia. If possible, this panel really should include SBDS. I just want to call out here that this is missing from the currently available Invitae panels, and that has been an option we have historically been able to reach for in some contexts to obtain free testing, but it does have this significant limitation. And this is really because SBDS has a highly homologous pseudogene, and so traditional sequencing approaches may miss SBDS pathogenic variants. It's also important to note here that even if you are starting GCSF because this kiddo is actively infected, but you want to be able to tell the difference between, is this an SCN presentation or cyclic neutropenia presentation, kiddos will still have cycling even while on GCSF therapy. All right, so in the last minute, we're going to just breeze through some broad strokes about GCSF treatment. So for immune neutropenia, we have that intact mobilizable pool. We're going to expect the response to GCSF to be pretty brisk and that we're not going to need very high doses. So you may start at 1 to 2 per kilo and decrease it as able, maybe landing even on as little as 0.5 per kilo per dose that may be able to be given on a spaced out schedule like a Monday, Wednesday, Friday. We do want to watch out for bony pain in these patients, which is a dose-dependent phenomenon. So if your patient's experiencing that, be sure to decrease the dose first rather than trying to space out the dose first. Other tips like giving it at night, doing a Tylenol pre-med, and then anecdotally, we hear from patients all the time that they feel their bony pain symptoms are improved with the use of a histamine blocker. I just want to highlight again that we shouldn't withhold GCSF therapy for a diagnosis of immune neutropenia if a child is having significant symptom burden. In SCN, instead of being a brisk response, we know that that response really requires neutrophil maturation, which can take 10 to 14 days. We're trying to push those neutrophils to mature and help them to survive. So you want to be starting more like 5 per kilo given daily. There are some genotype-specific guidelines, for example, for Cohen syndrome. And ultimately, you want to land on the lowest possible dose that can achieve an ANC nadir of maybe a little more than 1,000. It is worth noting, and you're going to counsel your families, that long-term GCSF therapy is associated with an increased risk of developing MDS or AML. But I also like to counsel families and make note of the fact that MDS and AML can still be observed even without GCSF treatment. And we do perform, at least at this day and age, annual surveillance bone marrow biopsy aspirate for these patients. And then lastly, for cyclic neutropenia, again, we still think that the response requires this neutrophil maturation or this pro-survival signal and may not be brisk. You may need to wait 1 to 2 weeks to see that response. We also call it that cyclic neutropenia treated with GCSF may still cycle, but the goal really is to reduce symptom burden for your patient. What you may see is that you shorten that nadir or you may raise how low that nadir ANC goes. Oftentimes for cyclic neutropenia, we'll start closer to 2 per kilo per dose and decrease as we're able, again, titrating really to symptom improvement. Often we're landing a little closer to 1 per kilo given on a Monday, Wednesday, Friday schedule. And this is an active area of conversation right now. Do we need to perform surveillance bone marrow biopsy and aspirate on cyclic neutropenia patients? And given that their risk of MDS AML is so much lower, it may not ultimately be required. And so just to highlight some takeaways on this final slide, we talked about many things today, but just to highlight again, neonatal and infant normal reference ranges are lower and based on some pretty sparse data. Duffy-null associated neutrophil count is something that you should be thinking about in your practice. You can see lower ANC normal values, but it's not a disease state and it's not associated with increased risk of infection. Immune neutropenia, fever precautions and follow-up schedule should really be tailored to the family and the patient that you're working with. If the case feels ambiguous, there's high anxiety, you want to have a little more certainty about what you're dealing with, you really can consider a steroid mobilization challenge. It may help you and the family feel confident that there is that mobilizable postmitotic pool. And just remembering that anti-neutrophil antibody testing can have poor sensitivity and specificity. Immune neutropenia that has significant oral manifestations should still be treated with GCSF. And when you're considering SCN or cyclic neutropenia diagnoses, you really want to be looking out for things like reciprocal monocytosis, consider genetic testing, and then really needing those frequent CBC monitoring for a long period of time to help you distinguish between these two entities. And then finally noting that should you perform a bone marrow biopsy in SCN and cyclic neutropenia, this really can vary based on the genotype. We didn't have time today to talk about things like emerging therapies or indications for hematopoietic stem cell transplant, but these are, of course, also really exciting topics in this area. And so with that, I'm happy to take any questions in the question and answer session in the chat or by email. And thanks so much for your attention.
Good morning. Our next speaker is Dr. George Zacur. Dr. Zacur is a pediatric gastroenterologist at the University of Michigan Mott Children's Hospital. He completed his pediatric gastroenterology fellowship at Cincinnati Children's Medical Center. He specializes in inflammatory bowel disease, advanced endoscopy, and also has a special interest in Shwachman-Diamond syndrome, as he helps to care for and manage the exocrine pancreatic insufficiency and growth restriction that is a known complication in SDS. This morning, he will be presenting his insights on pancreatic labs and imaging in Shwachman-Diamond syndrome. Please welcome Dr. George Zacur.
Hello. Thank you for having me today. My name is George Zacur. I'm one of the faculty here at the University of Michigan Mott Children's Hospital in the Division of Pediatric Gastroenterology, and I'll be discussing pancreatic labs and imaging in Shwachman-Diamond syndrome. I have nothing to disclose. Today, I hope to present a patient, discuss a little bit about how an atypically typical patient presents to our clinic with Shwachman-Diamond syndrome or the suspicion of Shwachman-Diamond syndrome. We'll discuss exocrine pancreatic insufficiency in the setting of Shwachman-Diamond syndrome, but also discuss a differential diagnosis. We'll discuss pancreatic labs in SDS. I'll discuss pancreatic imaging in SDS, a little bit of my experience and enzyme replacement for those with EPI in SDS, and then we'll summarize it at the end. Our patient's a 21-month-old boy who's described as generally healthy, but always appeared pale. At a well-child visit, the PCP decided to send some labs, which resulted in a trip to the emergency room and admission to the hospital for further workup. He had abnormal labs that showed a hemoglobin of 5.1, transferrin of 126, iron saturation of 82%. He was mildly neutropenic at 4.3 for his WBCs and an ANC of 900. He also had a reticulocyte count of 0.22, normal haptoglobin, alk phos of 1523, mild elevation in his liver enzymes, AST, ALT of 68 and 70 respectively. His LDH was mildly elevated at 396. Uric acid was normal at 4.5. He underwent a bone marrow biopsy, which showed mildly hypocellular marrow for age, with maturing myeloid elements, adequate megakaryocytes, and near absence of erythroid precursors. Flow cytometry was negative for leukemia. Cytogenetics showed a normal male karyotype. Parvovirus was negative. He presented with a prolonged course of normocytic anemia with reticulocytopenia requiring transfusions. He underwent a long list of testing that ultimately ruled out numerous diagnoses. However, abnormal telomeres were discovered, and abnormal liver and pancreas was found on imaging. So ultimately, the diagnosis of SDS was suspected. He was referred to the pediatric GI pancreas clinic, where we reviewed imaging and labs as well as growth. Fecal elastase was found to be undetectable at less than 50, and severe exocrine pancreatic insufficiency was described. Exocrine pancreatic insufficiency in SDS, the mechanism is unclear. We suspect because the SBDS gene mutation that involves the ribosome biogenesis and cellular stress response is abnormal, there's impaired functioning and survival of pancreatic acinar cells, leading to underdevelopment or degeneration. Lack of digestive enzymes ensues, including lipase, amylase, and proteases. We get a fatty replacement of the exocrine pancreas. There's improper digestion of fats, proteins, and carbohydrates. Malabsorption, steatorrhea, poor weight gain, failure to thrive, and vitamin deficiencies are found in EPI, in SDS, and other diagnoses. Those vitamins are specifically A, D, E, and K. The typical differential diagnosis of EPI includes small bowel intestinal bacterial overgrowth, or SIBO, Crohn's disease, celiac disease, chronic giardiasis, chronic pancreatitis, and the most common cause of EPI, cystic fibrosis. The pathophysiology of EPI in the non-SDS patient is usually a chronic inflammation and enzyme activation, such as in small intestinal bacterial overgrowth, disruption of enteropancreatic signaling, bile acid deconjugation, nutrient deficiencies and mucosal damage, a cyclical pattern of pancreatic disease resulting in SIBO with worse pancreatic function, pancreatic duct outflow and digestive hormone signaling, immune-mediated pancreatic injury, as seen sometimes in Crohn's disease, and an overall disruption of enterohepatic circulation of bile acid deficiency and fat malabsorption. Nutritional deficiencies affecting pancreatic function also part of the pathophysiology of EPI. So let's discuss pancreatic labs in SDS. Trypsinogen is a common lab sent in SDS. Due to the exocrine pancreatic dysfunction in SDS, the pancreas produces less trypsinogen. Serum trypsinogen levels are often low, especially in infants with SDS, indicating EPI. Trypsinogen increases, however, with age, so not an ideal marker for older children, especially without EPI or improvement in EPI. Isoamylase, which is why it's bolded, is specifically reflecting pancreatic amylase activity. In SDS, isoamylase levels are often low or undetectable due to EPI. So it's a helpful biomarker of pancreatic dysfunction in SDS, especially in infants and young children, where clinical signs might be nonspecific. In contrast to trypsinogen, low serum isoamylase levels remain low. Quantification fecal fat test is a stool test that we use in SDS. It's 72-hour stool collection. It's the gold standard for detecting fat malabsorption. It measures grams of fat excreted per day. A normal result is less than 7 grams per day on a 100-gram fat per day diet. It's significantly elevated in exocrine pancreatic insufficiency as well as SDS, but is a very painstaking test to perform and requires a specific diet. We oftentimes do not use this test for SDS or other conditions that have EPI. Rather than using the fecal fat 72-hour collection, we use the fecal elastase. It's now the most used stool for EPI screening. It's a non-invasive single stool sample. It's decreased in pancreatic insufficiency, including patients with SDS. Moderate insufficiency is described as less than 200 micrograms per gram, and severe is less than 100 micrograms per gram. It is more convenient and specific than fecal fat quantification, and there's no need to manipulate the diet or enzyme dosing. Let's discuss pancreatic imaging in SDS. MRI, or magnetic resonance imaging of the abdomen, is oftentimes used. It's the best imaging for detecting fatty replacement of the pancreas. It shows a bright or hyper-intense signal on T1 weighted images, indicating fatty infiltration. The pancreas can appear small, hypoplastic, or atrophic. The nice thing is there's no radiation exposure with MRI. It shows excellent contrast, but may require anesthesia for younger children. Additionally, we use CT scans to look at the pancreas. Also shows fatty replacement of the pancreas, low attenuation of pancreatic tissue due to fat content. However, there is radiation exposure, unlike the MR abdomen. Abdominal ultrasound, however, is preferred when looking for the pancreas and liver changes seen in SDS. It's first-line imaging. It shows a hyperechoic pancreas, bright on ultrasound, suggesting fatty infiltration. It can, however, be operator dependent. Bowel gas can get in the way. It is slightly less sensitive than MRI or CT. However, there's no radiation exposure and no anesthesia needed. If the ultrasound is normal or inconclusive and the patient has EPI, MRCP is the next imaging study of choice, regardless of SDS suspicion. Other tests that are important in the diagnosis or ruling out SDS is a sweat chloride test to differentiate between SDS and cystic fibrosis. The sweat chloride test is normal in SDS and abnormal in cystic fibrosis. Let's talk about pancreatic enzyme replacement therapy, or PERT, for EPI and SDS. Lipase, the most important enzyme for fat digestion and the most dosage sensitive, is one of those enzymes in PERT. Lipase is often the focus when titrating. Amylase, also in PERT, breaks down carbohydrates into simple sugars like maltose and glucose. And finally, protease, which breaks down proteins into peptides and amino acids. PERT enzymes are porcine-derived and therefore should be discussed with patients with specific religious beliefs or allergies. Our experience with PERT and growth in SDS is important. There are times where doses are initiated and or weight adjustments are made. In this patient, the child was malnourished, underweight, and the dose was initiated. And you can see a nice improvement in growth over time. However, that growth persisted and weight-based dosing was not adjusted until this point, where once again, weight increased. And again, more weight-based adjustments were made with further improvement in their weight and growth. Sometimes patients with SDS come without growth failure, as you can see in this child. However, because of symptoms of EPI, we started PERT, and there was nice growth over time. However, the child's family wanted to try to outgrow the dosing, and the child's growth plateaued. Ultimately, dose changes were made based on weight, and there was a significant improvement in growth. Our experience and expectations for those with EPI and SDS are improved growth for those who present with growth failure, improved symptoms of steatorrhea, abdominal bloating, nausea and abdominal pain, and normal fat-soluble vitamins, specifically A, D, E, and K. We oftentimes get the question of whether or not EPI will resolve in patients with SDS. Some patients have shown improvement in the exocrine pancreatic function over time. Testing results such as your elastase or 72-hour fecal fat collection will normalize, and PERT is no longer needed. Although testing is normal and PERT can be discontinued, technically pancreatic function remains abnormal. So in summary, we currently suspect there's the SBDS mutation causing impaired ribosome function, leading to acinar cell dysfunction and death, followed by pancreatic fatty replacement, decreased enzyme production, and ultimately exocrine pancreatic insufficiency. Isoamylase is the best serum marker to start out with. Fecal elastase is also the better stool test to start out with. And abdominal ultrasound is the least invasive imaging study to start out with for the diagnosis of SDS. A referral to PGI or nutrition is also helpful, especially for pancreatic enzyme replacement therapy for those who have exocrine pancreatic insufficiency. Thank you for your time.
For our last presentation, I would like to introduce Dr. Kasiani Myers. Dr. Myers completed her pediatric hematology-oncology training at Cincinnati Children's Hospital Medical Center. After completion of her training, she joined on as faculty in the Division of Bone Marrow Transplantation and Immune Deficiency at Cincinnati Children's, where she's an associate professor as well as director of the Bone Marrow Transplant and Late Effects and Survivorship Program. Her clinical and research interests are in bone marrow failure syndromes, including Shwachman-Diamond syndrome. She also serves as co-director of the North American Shwachman-Diamond Syndrome Registry. We are honored to have her here today to present malignant transformation in Shwachman-Diamond syndrome. Remember, following her presentation after the break, please join us for our live fireside chat. And without further ado, Dr. Myers.
Hello, and thank you all for inviting me here to talk about malignant transformation in Shwachman-Diamond syndrome. These are my disclosures. I do have research support from Insight and Elixirgen Therapeutics and serve on various relevant foundational advisory boards. I'd like to start off with a case, and this is a case of an 11-month-old little boy who is being seen in bone marrow failure clinic. He had a prenatal diagnosis of short ribs and skeletal dysplasia with short, long bones. He also had a small chest wall, which led to the development of small lungs. Also noted on exam were syndactyly of his toes. He had failure to thrive, requiring G-tube nutrition, and was found to have pancreatic insufficiency, requiring enzyme replacement. He had normal blood counts and normal genetic testing for June syndrome and short rib polydactyly syndrome type 2. Due to his pancreatic insufficiency, he was tested for Shwachman-Diamond syndrome and did in fact carry a homozygous mutation for the SBDS gene, and this is the most common mutation found in patients with Shwachman-Diamond syndrome. Shwachman-Diamond syndrome is an inherited ribosomopathy characterized by bone marrow failure and high risk of myeloid neoplasms that present early in life. It is predominantly caused by biallelic germline mutations in the SBDS gene, which is critical for ribosome assembly. The SBDS protein is required for the formation of a mature, translationally active ADS ribosome. SBDS cooperates with EFL1, a GTPase, to remove EIF6 from the 6DS subunit. SBDS deficiency leads to decreased ribosomal joining and reduced translational efficiency. This ribosomal stress activates cellular pathways of senescence and results in global fitness defects in stem cell maintenance, resulting in bone marrow failure, but also leading to an increased risk of myeloid malignancy, which we'll be talking about more today. As I mentioned, the vast majority of patients with SDS have autosomal recessive mutations in the SBDS gene, although there are patients with SDS-like phenotypes who have mutations in SRP54, DNAJC21, and EFL1. These are all proteins associated with ribosomal assembly pathways. The classic presentation for patients with SDS includes neutropenia, which is often intermittent and may be missed on CECs, steatorrhea, and failure to thrive. The median age for malabsorption is actually quite young, typically soon after birth, but may range up to 11 years of age. These patients have significant pancreatic dysfunction leading to the steatorrhea and failure to thrive. Characteristic physical abnormalities seen in SDS include short stature, metaphyseal dysostosis, and thoracic abnormalities, such as in the case described previously. About 50% of patients indeed have congenital anomalies associated with their disease, and neurodevelopmental manifestations are quite common. Now, we just discussed what the textbook says about Shwachman-Diamond syndrome, but the diagnosis is not always straightforward. In fact, it can be quite cryptic. There is a broad spectrum of clinical phenotype in patients with SDS. And actually, 50% of patients with SDS do present without the classic combination of neutropenia, failure to thrive, and diarrhea. In addition, patients that are asymptomatic have been reported when undergoing testing related to siblings who have been diagnosed with Shwachman-Diamond syndrome. This is actually a critical point in related donor selection when thinking about stem cell transplant. Additionally, mild phenotypes presenting in adulthood with MDS or AML as their first presentation of Shwachman-Diamond syndrome have been reported. In fact, Coleman-Lindsley from Dana-Farber collaborated with the CIBMTR, the United States Transplant Registry, and demonstrated previously undiagnosed individuals with Shwachman-Diamond syndrome within a cohort of patients transplanted for MDS. And these patients had significantly poorer outcomes. Touching briefly on management, I know this has been discussed a little earlier, but neutropenia with severe or recurrent infections can be treated with chronic G-CSF therapy in some instances. Other care is mostly supportive, again, G-CSF or transfusional support as needed intermittently, specifically for procedures, etc. Pancreatic insufficiency is treated with enzyme replacement and vitamin replacement. And then patients are screened for malignancy. CBCs are recommended every 3 to 4 months. And although the field hasn't settled on a frequency for bone marrow screening, I would recommend a bone marrow evaluation every year. And we'll talk a little bit more about what to include in that evaluation and why later. Patients with severe aplastic anemia, MDS, or AML are, of course, offered stem cell transplant, which is currently the only curative treatment for patients with Shwachman-Diamond syndrome. Longitudinal data across several registries across the world, including the North American, French, and Italian registries, have shown a variable but increased incidence of myeloid malignancy ranging from 10 to 30%, although follow-up is limited in adulthood in these cohorts. There are active efforts currently to combine international data from over 14 countries in the hopes to demonstrate the true risk of myeloid malignancy with age. So more to come on that in the future. Importantly, it's also notable that transient or persistent clonal changes are commonly seen in patients with Shwachman-Diamond syndrome, including isochromosome 7 and del20q. And these are not associated with an increased risk of malignant transformation in isolation. Although monosomy 7, of course, is quite worrisome when seen. Now, a few years back, the STS registry led a collaboration of over 17 institutions to look specifically at outcomes of myeloid malignancy in patients with Shwachman-Diamond syndrome, and unfortunately found that outcomes were quite poor, with a median survival of 7.7 years for MDS and only 1 year for AML, and an overall survival of 51% for MDS and 11% for AML. Patients in this cohort had central pathology review with updated diagnostic criteria to more modern criteria, and were found to have a high incidence of high-risk features such as complex karyotypes and TP53 mutations. They also had very high rates of treatment-related toxicity, as well as high relapse and refractory disease rates. Importantly, there was a survival advantage in patients undergoing active bone marrow surveillance compared to those without, with an overall survival of 62% with surveillance compared to 28% without. So I'm going to walk you through another illustrative case here. And this is a case of a 25-year-old previously healthy young man who was found to be anemic and thrombocytopenic on labs obtained due to fever and ankle pain. A bone marrow was eventually obtained and found MDS with complex cytogenetics, as you can see listed here. NGS demonstrated a TP53 mutation with a VAF of almost 94%. This patient progressed to AML during his MDS-directed therapy and subsequently received AML-directed therapy. Germline testing was obtained at an end-of-cycle marrow evaluation due to increased toxicity with AML-directed therapy, specifically infectious and cardiac toxicity. And the patient was found to have biallelic SPDS gene mutations consistent with a diagnosis of Shwachman-Diamond syndrome. He eventually proceeded to stem cell transplant with a partially matched unrelated donor. And his day 30 bone marrow evaluation was MRD negative, although it did have some low-level mixed chimerism. Unfortunately, he experienced a frank marrow relapse 3 months later, and his course was complicated by multi-organ graft-versus-host disease and atypical mycobacterial infection. He eventually passed away with refractory AML and active infection. These data and poor outcomes highlight a critical need to better understand malignant transformation in patients with Shwachman-Diamond syndrome. In order to do this, the STS registry partnered with Coleman Lindsley at the Dana-Farber, and Alyssa Kennedy, when she was a postdoc in Akiko's lab, did this really elegant work that I will walk you through in the next several slides. This project capitalized on over a decade of sample collection in the registry using longitudinal paired bone marrow and fibroblast samples. So thank you to everybody who has enrolled patients in our registry. These data are a direct result of this enrollment. These samples were initially looked at with whole exome sequencing in a discovery cohort of 29 subjects with SPDS mutations, including 12 with myeloid neoplasms, to identify recurrently somatically mutated genes, and then subsequently using targeted sequencing in a larger validation cohort that included mostly patients with SPDS mutation, but also one with the DNA JC21 mutations, and 11 genetically undefined patients with an SDS phenotype. In the 12 patients with myeloid neoplasm, somatic alterations were seen, including TP53, RONX1, SETBP1, BRAF, NRAS, and ETNK1. Also seen were recurrent structural alterations involving chromosomes 3, 5, 7, and 20. In the patients without myeloid neoplasm, they observed frequent deletions of chromosome 20q in almost half of patients, and recurrent mutations in EIF6, almost 30 patients. Importantly, somatic TP53 mutations were found both in patients with and without myeloid neoplasms. Targeted sequencing included 55 genes, specifically those that were recurrently mutated in the discovery cohort, and genes involved in sporadic myeloid neoplasms in the general population. Here you see gene mutations on the x-axis going down and individual patients in the columns across. TP53 mutations in red were more common in SDS patients with myeloid neoplasms than those without, and that is statistically significant. EIF6, PRP8, and CSNK1A1 were not associated with myeloid neoplasms. No somatic mutations were observed in genetically undefined patients with SDS-like phenotypes on the far right. Overall, we detected a total of 327 somatic mutations in 76% of SDS patients with germline SBDS mutation. This is a median of 2 mutations per patient, but ranged widely between 0 to 21 mutations in any given individual. Mutations in EIF6 and TP53 were the most common by far. And most of the patients with somatic mutations had more than one, frequently affecting the same gene. These were most commonly base substitutions, C to T, that are predominantly seen as an aging signature in normal aging stem cells, as well as sporadic clonal hematopoiesis and AML in the general population. The presence of somatic mutations was associated with older age, although patients did have mutations starting at a very young age. Initial bulk sequencing demonstrated that almost 91% of patients with SDS and TP53 somatic mutations also had concurrent EIF6 mutations, raising the question of whether these mutations were in the same clone or separate clones. So looking further with single-cell sequencing on over 33,000 cells from 6 patients with SBDS mutations and clonal hematopoiesis, we were able to demonstrate that these somatic mutations were almost always present in independent clones, as you see here. Of a total of 50 clones identified, 24 had EIF6 mutations alone, 21 had TP53 mutations alone, and 3 had isolated CSNK1A1 mutations. These representative images show 5 separate subjects with individual clones on the y-axis and separate mutations on the x-axis, with TP53 shown in red and EIF6 in blue. You can see that in the vast majority of cases shown here, the mutations are isolated in separate clones. There is one patient on the far right in which a TP53 clone also later acquired an EIF6 mutation as a subclone. It's important to note that this demonstrates that clonal hematopoiesis is common in Shwachman-Diamond syndrome and occurs at a young age. In a total of 83 patients with SDS without an MDS or AML diagnosis, 60 or 72% had detectable clonal hematopoiesis. 40 of those had more than one mutation. Interestingly, typical mutations found in clonal hematopoiesis in the general population, such as DNMT3A, TET2, ASXL1, were very rare. In fact, only one of each were identified in the cohort. The percentage of clonal hematopoiesis also increased with age. Over half of patients less than 10 demonstrated clonal hematopoiesis, almost 90% of those between 10 and 20 years of age, and 100% or all of the patients in the cohort over 21 years of age demonstrated clonal hematopoiesis. Importantly, during this work by Alyssa, Akiko, and Coleman, we looked at the typical patterns of somatic mutations in SDS patients without malignancy over time. We track these somatic clones over time in bone marrow samples of multiple patients with SDS who did not have MDS or AML, as depicted on the left in two representative plots. We found that somatic EIF6 mutations in blue and TP53 mutations in red were present at low variant allele frequency for many years in patients with SDS without the development of myeloid malignancy. The median variant allele frequency of these somatic mutations was below 1%, as shown in the bar plot in the middle graph. In addition, the fold changes in VAF over time was minimal, shown on the right-hand side, with most somatic clones remaining stable at a low VAF over time. Based on this data, we defined high-risk somatic mutations as somatic mutations in TP53 or other high-risk driver genes with a VAF of at least 3% in at least 2 consecutive bone marrow exams. So, what takes the somatic clone and pushes it over into a malignant clone in patients with Shwachman-Diamond syndrome? Specifically honing in on the patients with myeloid neoplasms and Shwachman-Diamond syndrome, looking by exome sequencing, all 7 patients had biallelic alterations in TP53. 3 of the 7 had additional somatic mutations that are typical myeloid drivers, such as NRAS, KRAS, and PTPN11, which were rarely present in samples without morphologic transformation. Well, next we wanted to know how long had these clones been present before the clinical diagnosis of AML. And I show you here one representative graph of a patient with SDS who progressed to AML. And you can see there the malignant clone in retrospect. I will remind you that these are samples that had been banked, was detectable 4.5 years prior to the AML diagnosis. But of course, this is only if one knew what to look for and was only present initially at a very low VAF frequency, well below any clinically available testing platforms. However, over time, you can see that clone grew into detectable levels prior to the AML diagnosis. Unfortunately for this patient, this was prior to the era of clinically available NGS testing and was only noted in retrospect on testing of banked samples. Here's another representative example of this process, where it's a little easier to see the trajectory of the clones and the variant allele frequencies. We're looking at NGS in a patient with Shwachman-Diamond syndrome undergoing serial bone marrow examinations. TP53 and EIF6 mutated clones are colored red and green, respectively. The solid red line corresponds to the biallelic TP53 clone that eventually progressed to MDS. The light blue bar highlights year 3 of bone marrow surveillance. On the right, we see that single-cell DNA sequencing at year 3 of surveillance. Each row represents a unique EIF6 and TP53 mutated clone with a VAF percentage as below. Each dot represents a single cell belonging to that given clone. Heterozygous mutations have a VAF of 0.5. The TP53 mutation in clone 3 has a VAF of 1.0, indicating biallelic TP53 mutation. The biallelic TP53 mutated clone expands exponentially and represents the dominant clone at the time of MDS diagnosis, there on the left. This clearly demonstrates the ability of single-cell DNA-seq to reveal the clonal hierarchy of somatic mutations and identify high-risk TP53 mutations years before a clinical diagnosis of myeloid malignancy. Through this work, we've identified detectable biallelic TP53 mutated clones using single-cell that eventually gave rise to leukemia despite no other concerning clinopathological or cytogenetic features during routine bone marrow and blood counts only a few months prior to the leukemia diagnosis, highlighting that the window is sometimes quite small for some patients. So as a summary, SPDS deficiency results in impaired ribosome assembly, decreased cell fitness, resulting in bone marrow failure. Work from our registry that I just discussed and from other groups has shown that this poses a significant drive for somatic clones that improve cell fitness, but depending on the mechanism, result in divergent clinical outcomes. Somatic loss of function mutations in EIF6 represent an adaptive somatic rescue that alleviates the underlying ribosomal defect and improves cell fitness with reduced leukemia risk in clones harboring the EIF6 mutation. In contrast, acquisition of heterozygous mutations in TP53 leads to improved cell fitness without affecting the germline ribosomal defect. And subsequently, biallelic TP53 inactivation is associated with progression to MDS or AML. So while patients with SDS can have clonal hematopoiesis with TP53 and EIF6 mutations existing in parallel for many years, it is in fact the acquisition of that second TP53 mutation that leads to the development of myeloid malignancy through the loss of cell checkpoint and genomic instability. This argues for the addition of NGS sequencing to bone marrow surveillance screening. Although single-cell sequencing is not available clinically, it can be challenging to tease out the significance of individual clones in the absence of single-cell. So we would recommend consultation with an expert for help with interpretation and consideration for timely referral to transplant in patients with evolving TP53 clones. I spent a long time talking about myeloid malignancy in Shwachman-Diamond syndrome, but I do want to touch briefly on some very new data on risk of lymphoid malignancy in Shwachman-Diamond syndrome. And this is brand new data just published this year, work done by Helen Reed in conjunction with the SDS registry. Within the North American SDS registry, 4 of the 217 subjects with biallelic SPDS mutations have developed a lymphoid malignancy. This is an observed risk that is 38-fold higher than that of the general population. And in fact, these patients did have increased toxicities with further therapies, and one went on to develop AML after the initial lymphoma therapy, in addition to developing what appeared to be a second lymphoma based on genetic testing. These data potentially argue for consideration for transplant in the setting of the original lymphoma, given the potential risk of therapy-related additional lymphomas or AML, in addition to the baseline background increased risk from the germline SPDS mutations. So more work to come in this area as well. So we've talked a lot about the data on malignant transformation. How do we use these data? There's controversy regarding the timing and type of surveillance for myeloid malignancy that patients with SDS should undergo. And we're actively debating this at the moment as we revise and develop new consensus guidelines for patients with SDS. And so stay tuned. This is a worldwide effort to update the guidelines. But for now, I will share with you our current registry surveillance recommendations. We do recommend that regular blood counts be performed every 3 to 4 months. We want to highlight, however, that regular blood counts can be helpful, but blood counts alone are insufficient. Even patients with mildly low blood counts still remain at high risk for leukemia based on registry data. Bone marrow examinations are important because they share extra granularity and clues to impending leukemia risk. Morphology is important to tell us how the cells are looking for dysplasia. Cellularity helps with marrow structure. Cytogenetic testing will tell us about acquired chromosomal abnormalities, again highlighting that isochromosome 7 and del20q are common in SDS and not of concern if they are present in isolation. FISH studies look for specific acquired chromosome abnormalities that can be critical and high risk. And then flow will help us look at maturation patterns. Newer, based on these registry data, are the recommendations for somatic mutational analysis, and this is specifically looking for those TP53 mutations. We would recommend NGS sequencing, including TP53 sequencing, and we would also suggest that a microarray to look for loss of heterozygosity as a second hit for TP53 could also be performed. This has been described in several patients within the registry. How often should we be doing those bone marrow surveillances? We do believe that one may defer the first marrow in patients diagnosed very young until age 2 if the blood counts are not concerning. And this is to help with anesthesia risk. But then after the age of 2, we do recommend that marrow surveillance continue annually, as we do see that there are patients who transform very quickly. It is a partnership between physicians and families, and making the decisions about the frequency of surveillance and taking into account quality of life. But given the high risk of mortality in this setting, we do believe that frequent evaluations are warranted. There is active research into the potential use of blood surveillance in conjunction with marrow surveillance is actively being looked at in the registry at the moment. So again, more data to come on that as well in the future. So one final case to illustrate a bit about how we're going to start using these data in the clinical setting with the hopes of moving the needle and changing these survival curves we talked about at the very beginning. This is the case of an 8-year-old young man with Shwachman-Diamond syndrome who was referred for stem cell transplant due to persistent clonal evolution secondary to his underlying SDS. He was initially diagnosed with SDS while in the NICU due to cytopenias and prolonged respiratory distress, and had been supported with once-weekly G-CSF at the time of referral. His bone marrow showed maturing trilineage hematopoiesis with no morphologic evidence of dysplasia. His FISH panel for myeloid disorders was negative, and the chromosomal studies were normal. NGS sequencing, however, showed persistence of TP53 mutations at a VAF of 3% or slightly higher. This patient proceeded to stem cell transplant with an unrelated donor and is currently more than 6 months post-transplant. His course was complicated by some mild GI graft-versus-host disease, as well as lung graft-versus-host disease and CIV viremia, all of which have resolved. His most recent bone marrow evaluation, which was 6 months after transplant, demonstrated full donor chimerism with no evidence of the TP53 clone. So transplant, as we've discussed, is the only potentially curative option for the hematologic disease in patients with Shwachman-Diamond syndrome. The diagnosis of Shwachman-Diamond syndrome when considering transplant is critical. Transplant is a high-risk therapy and should be approached thoughtfully. The diagnosis is important because transplant within the inherited bone marrow failure diseases is challenging due to inherent but variable chemotherapy and radiation sensitivities. So choosing the right preparative regimen is critical. The right timing is also critical. As I mentioned, this is a high-risk therapy, and preemptive transplant is not for all. So when do we consider transplant in patients with Shwachman-Diamond syndrome? Well, certainly in the setting of severe aplastic anemia with transfusion dependence or persistent severe neutropenia with recurrent infections. Also similarly with high-risk cytogenetic abnormalities such as monosomy 7. And just repeating one more time to make sure that it sticks, that del20q and isochromosome 7 are very commonly seen in SDS and are not high-risk features for transformation alone in the absence of other cytogenetic or morphologic changes, and are not indications for transplant. Of course, we do offer transplant in the setting of MDS or EML, but we've seen those outcomes are poor. So a newer indication for stem cell transplant is consideration for transplant in the setting of clonal evolution, for patients with high-risk disease features, including those TP53 mutations that are evolving and changing. While we know that stem cell transplant is the only potential curative therapy, historically, outcomes of full intensity transplant were quite poor. Today, I'm looking forward and focusing on some of the advances in the field of transplant for SDS and where we hope to go in the future with this therapy, highlighting improvements in transplant regimens and risk stratification. Now, a few years back, 2 papers were published, one from the CIBMTR, the United States-based transplant registry, and one from the EBMT, the European-based transplant registry, with 52 and 74 subjects respectively. They both demonstrated improved survival in patients with bone marrow failure and SDS at 74%, labeled here in the graph as primary SDS, but still poor survival of 15% in those presenting for transplant with MDS or AML. These improvements in bone marrow failure outcomes have come largely after the start of reduced intensity and reduced toxicity regimens for Shwachman-Diamond syndrome. Although the registry studies I just mentioned in the previous slide did not have the power to show that statistically. 2 examples here listed are one reduced intensity approach using Campath, fludarabine, and melphalan, and one reduced toxicity approach, maintaining myeloablative treatment with triosulfan, fludarabine, and ATG with lower toxicity. Both have shown excellent outcomes in the setting of bone marrow failure, but outcomes for MDS or AML still fall behind. Focusing on the triosulfan-based approach, and this is a trial for inherited marrow failure, which enrolled 4 patients with SDS that was led by Lori Burrows. Outcomes you can see here are excellent, with an overall event-free survival of 96% and a GVHD event-free survival of 87% at a median follow-up of 2 years. Clinically, the toxicity of mucositis and nausea is significantly less in this regimen, and there's a significantly lower risk of VOD as well. This great work led to a new protocol through the BMT-CTN with Lori Burrows as a PI. BMT-CTN 1904 is a prospective, multi-center phase 2 study that was designed to evaluate outcomes of patients with bone marrow failure disorders undergoing stem cell transplant using a triosulfan-based conditioning. And again, this is triosulfan, fludarabine, and ATG. It was a single-arm study without randomization, and I'm happy to say it has now fully enrolled as of February of 2025 and included 11 patients with Shwachman-Diamond syndrome. Final results of this trial will not be available for approximately a year from now, as the primary endpoint is at 1 year from transplant. But our experience has been promising. Through participation in studies like this with a multi-center, uniform approach, we hope to continue to advance less toxic approaches to transplant for inherited bone marrow failure, including for patients with Shwachman-Diamond syndrome. Just wanted to highlight there at the end that patients with MDS or leukemia were excluded for this study. This was a marrow failure study exclusively. So in this spirit, we're in negotiations for a new clinical trial using triosulfan-based transplant regimens for patients with inherited bone marrow failure and the diagnosis of MDS or AML. And this is another collaboration with Dr. Lori Burrows and Dr. Ann Dahlberg in Seattle that will be open to patients with SDS. So stay tuned. Again, more to come on this as well. Switching gears a bit from how we transplant to how often and looking a bit more granularly, these are data from the US-based SDS registry. At the time of this analysis, there were 293 subjects that were genetically defined in the SDS registry, as you see here. The vast majority, 88%, have biallelic SPDS mutations. 62 of these subjects have gone on to a stem cell transplant. Again, the vast majority of them being individuals with SPDS mutation. However, 1 patient with DNA JC21, 1 with SRP54, both with high-risk features went to transplant, and 1 patient with SRP54 to transplant secondary to the development of AML. Focusing on the patients with SPDS mutations, of those transplanted, about a quarter were for bone marrow failure, 35% for myeloid malignancy, and 30% for high-risk features, which I'll go into more detail about here in a moment. Other transplant indications included cytogenetic and clonal changes no longer considered to be an indication for transplant for Shwachman-Diamond syndrome. Diagnosis of a germline predisposition syndrome like SDS offers the opportunity for surveillance to flag patients at high risk for clonal progression. Due to the high mortality associated with MDS and AML that we've been discussing in Shwachman-Diamond syndrome, we have started to use concerning clonal evolution, specifically that of TP53, as a potential indication for transplant. This is done with shared decision-making with patients and families. The hope is that early intervention in high-risk patients may prevent progression to malignancy. However, the outcomes of bone marrow transplantation in high-risk patients with germline predisposition syndromes have not been studied systematically. So through the registry, we've now aimed to investigate the outcomes of transplants for patients with high-risk features and Shwachman-Diamond syndrome. We also wanted to compare the survival outcomes of patients with SDS transplanted for high-risk features to the survival outcomes of SDS patients transplanted for MDS or AML. This is focused on patients with biallelic SPDS mutations, as the numbers in other genetic etiologies are very small. And we use the data on prevalence, persistence, and variant allele frequency that I just discussed at length to define the high-risk somatic mutations as somatic mutations in TP53 or other high-risk driver genes with a VAF of at least 3% in at least 2 consecutive bone marrow exams. These data are still in analysis and remain unpublished, so unfortunately I will not be able to share the complete analysis today, but I will say stay tuned, and we're excited about these preliminary results. So while these new results are potentially very exciting, and we are improving our diagnosis of Shwachman-Diamond syndrome, there are still some patients who will present with MDS or AML, sometimes as their first presentation of SDS. Traditional high-intensity chemotherapy historically has met with significant toxicity and resistant disease in this setting. So we really need to change our approach. Certainly, one way is with novel surveillance and transplant strategies, which we've been discussing, but also novel therapies to address the AML front are critical. Leukemia therapy has evolved over time in general and is becoming more targeted, and the use of less cytotoxic agents is becoming more common. Targetable therapies can be used if targets are identified by sequencing panels, such as JAK mutations and the use of ruxolitinib, for example. Hypomethylating agents, such as azacitidine or decitabine, in combination or alone with targeted agents, or with venetoclax, are a promising and potentially less toxic approach that has been used in older adults. These efforts in the US have been led by Courtney DiNardo with some promising outcomes in older adults, although early data suggests this may be less promising in the patients with TP53 mutations. This is anecdotal, but we have some institutional experience in Cincinnati with this approach in the setting of patients with SDS and with Fanconi anemia and AML, both in the upfront and post-transplant use of these agents. Some of these agents have been successful in temporizing disease as a bridge to transplant, but are not as promising as hoped with some eventual relapses. Other novel approaches, such as antibody-mediated and cellular therapies, are being developed and tested as well. We do have a new clinical trial open in Cincinnati led by Zara Huda for the use of cytokine-induced memory-like natural killer cells for relapsed and refractory AML, for which patients with inherited marrow failure, including Shwachman-Diamond syndrome, may be eligible. And I'm aware of several different cellular therapies that are in the process of development. So in summary here, and looking forward for our patients with SDS, outcomes have improved, but we need to continue to improve outcomes even further. We need improved markers for early identification of high risk and impending leukemias for potential early referral to transplant, Again, the follow-up is short in this setting, but the initial results look promising. We need to develop novel approaches for treatment of MDS or AML and work on alternative transplant strategies, specifically in clinical trials such as the BMT-CTN. It's so important to advance the field to treat patients in a uniform way. And really, this can only be done in multi-center trials. So more clinical trials for which patients with inherited marrow failure are eligible will be critical. Alternative strategies, such as haploidentical transplant for patients with Shwachman-Diamond syndrome and other inherited bone marrow failure syndromes, antibody-based approach to preparative regimen, as well as gene therapy, are still emerging approaches in this field, but very interesting. So a few final thoughts. Stem cell transplant is the only current curative treatment for hematologic disease in Shwachman-Diamond syndrome, including bone marrow failure, clonal evolution, and myeloid malignancy. This decision to go to transplant, however, needs to be made with a team experienced with Shwachman-Diamond syndrome. Stem cell transplant approaches should be SDS specific to decrease early and late toxicities. And I hope I've shown you that our data support screening for high-risk features with next-generation sequencing for consideration for early transplant prior to the development of MDS or AML. High-risk features were unfortunately identified in 9% of SDS patients in the US-based registry, and we believe that elucidation of clonal patterns and their functional consequences can be critical to guide rational surveillance and treatment strategies. There is an SDS board available through the SDS registry, which is available for consultation with treating physicians to help interpret NGS findings, as this is really the cutting edge of therapy, and these decisions are obviously high risk. And finally, one more plug for multi-institutional trials. We really need to develop less toxic approaches for bone marrow failure therapy, as well as novel approaches for the treatment of MDS or AML. As I conclude, I'd like to thank Akiko Shimomura, who's really my partner in crime and co-directs the SDS registry with me, as well as everyone who's participated and contributed to these projects, and especially, most of all, the patients and their families, without whom none of this work is possible. And of course, our funding. Thank you for your attention, and I look forward to your questions.
Thank you all for joining us for today's Nicer Education Camp on Shwachman-Diamond, and thanks for hanging around for the live fireside chat. Before we get started, I just wanted to also say thanks to our speakers who provided excellent talks today. And thanks for hanging around so we can have a good discussion. We've already had a lot of questions come through the Q&A, so we'll get started asking those. If you have any other questions, please put them in the Q&A, and Dr. Connelly and I will bring those up to the speakers. To get started, Dr. Zacur, there was a lot of questions coming in talking about PERT and particularly the complications that you see as far as the liver. So if you wanted to get started on that.
So in terms of, let's start about the liver. It's interesting. I think the liver also gets a little bit of love when it comes to SDS. We oftentimes will see some steatosis, some fatty replacements similar to the pancreas. However, I will say it's not something that's very damaging. You'll see some mild elevation in liver enzymes, AST, ALT, that maybe will over time improve or may stay sort of stably abnormal, but you're not going to see liver failure, abnormal INR, or abnormal albumin. It never progresses to anything more than just some changes on imaging and some mild elevations that will sometimes also resolve. Maybe the fatty replacement doesn't completely resolve, but the liver enzymes can improve to completely normal in some patients. Obviously we focus on the pancreas a lot more, but we're focusing on vitamins A, D, E, and K for your fat soluble vitamins. So the liver rarely has enough damage to cause any problems. And the recommendations we usually give are the same thing that you would give for anybody else with steatosis, which is, be careful with other hits to the liver, such as toxic medicine, obviously alcohol, things like that, herbs and supplements that need to be reviewed with immunohematologist or gastroenterologist. But anything else that could damage the liver, you're going to notice a bump in those enzymes, and same thing with infections, viruses, what not. But they should all, recover for the most part. But other than that, I've never had a patient who had such rip-roaring liver disease that required either consultation by my hepatology colleagues or myself. We had one patient who was quite young, and the workup was being done for SDS, and the fatty replacement looked like a mass. So immediate, concern for malignancy, and ultimately this patient re-imaged, and I think it was an overread by our radiologist from the read from the outside, or imaging from the outside hospital, and they said it's just fatty replacement. It just looks very clumpy or clumped like a mass, but in reality it was just fatty replacement, and the liver is fine, completely normal function. So we don't get a lot of liver disease, and I hope I answered that question well from the Q&A. In terms of PERT, we don't get a whole lot of side effects from PERT. As I mentioned I answered the question about side effects or the damage. Growth is extremely important. And it's not like, oh, we're going to treat and then we'll deal with any damage that may happen. But it's so important at all the stages of development, at all ages, to have good growth. So we will oftentimes, and I put it in the chat, or the way I answered it in the Q&A, was sometimes we have to get creative. That same patient I was just talking about, he had an oral aversion because of, I don't know what developed the oral aversion, because again, he transferred from a different hospital, but we had to deal with this oral aversion, and how are we going to get PERT inside a 15-month-old? So NJ tube, we mix it in this, we try that, we put it in different things. And then you have to think about acid. So do you put them on a PPI, but you want breakdown, so then you don't put them on a PPI, but PPIs and H2 blockers have been oftentimes used to help PERT work. I don't worry about that so much. So I make sure that the children grow, and if we do see side effects, then we have to reassess, is the growth good, where we can now potentially back off a little bit. But in reality, I've only had to do that once for someone with really horrible constipation that we suspected was from the PERT. Otherwise, any constipation that may occur after starting PERT is usually because we've treated the steatorrhea, and I was kidding a little bit, constipation is an epidemic in our country. So I think it's just sometimes you unmask the constipation that was going to happen anyway. But that's my experience with PERT, and then also the liver. Hopefully I answered that question well. If I can expand more, please let me know.
Thanks, George. And again, thanks for really amazing speakers today. I think all three of you, I always learn so much from you guys, and I really like the caveats and some of the nuances that you always are willing to share with your practice. George, I just had a follow-up question, and this is for all the panelists, is, what's your understanding of why some of the features of SDS improve with age, right? So you had mentioned that some of the liver abnormalities you can see in younger patients, at least based on enzyme testing, improve. In your talk, you also mentioned that the pancreatic function can vary over age and sometimes improve. Do we feel that's, actually the organ itself is improving? Is this a feature as the diet changes from, as from toddler to adolescent to adult? Because as far as we know, and maybe Cass, you could answer this, is if there is any, because we know about some of the somatic changes that happen in the bone marrow, but I'm curious if we think any of these occur in non-hematopoietic tissue, and perhaps that is why we see some changing phenotypes over time.
That's a great
question. Yes, you want to go ahead? Yeah, go ahead. You first.
Yeah, that's a great question. And the short answer is we have no data, and nobody's actually looked at that, but it would be really interesting to do. It certainly seems like a plausible possibility, and agree that most of the non-hematologic and even some of the hematologic disease manifestations kind of wax and wane with time. Even the blood counts can show some improvement in those patients who don't go on to develop marrow failure or malignancy. Interestingly, we are in the process of analyzing the liver data for the registry, and we do see that, just as you said, Georgia, high prevalence in younger patients of transaminitis that improves in probably a third to maybe half of them over time, but never at younger ages really causes significant liver disease. There are some isolated reports of adults with liver failure. It's not clear what the reason is for that liver failure, and it's not generally transplant associated. So that's one other thing, when you think about these patients who have this history of, transaminitis, either historical or chronic, people worry about taking them to transplant and exposing them to toxic chemotherapy, and they actually tolerate it pretty well from a liver standpoint. So yeah, another area that we need to work on a bit more, because a bit, as you say, potentially may be able to capitalize on why these symptoms improve and use that to develop better therapies.
From a pancreas standpoint, it's sort of the same thing. We just don't have data. We know that it can improve, and we predominantly do fecal elastase. I haven't done a fecal fat collection, a 72-hour, I think, ever, or in a very long time. I know other places do it because you can do it in-house versus send out and things like that. But those are the tests that will improve. But if you actually were to do pancreatic stim and actually analyze pancreatic function, that doesn't change or that doesn't improve. But we don't know why elastase will get better, and they can sometimes get off of their enzymes. I feel like my population right now of SDS is on that younger side, and they are now getting into the toddler or to the school age range, since I've been doing this now for a little bit. And I have a few teenagers. Their numbers, and I check every once in a while, knowing that they're still requiring adjustments in their PERT, which tells me that they still have insufficiency. But I will say, as I'm checking every couple of years or maybe even every year, those elastases are improving slightly. And I will tell families that once you hit that 200 range, doesn't mean just because you hit 200 doesn't mean you don't need PERT anymore. So I'll continue the PERT until they're well into the 200, 300. I mean, I don't know if they'll ever reach undetectably high levels, like greater than 500. But when I've seen that they've hit that 200 consistently, then we can trial them off of their PERT. And it's just trialing off or letting them outgrow the dose and using very minimal, or maybe using it for high fatty meals if they want to, have a treat once a month or once a week or whatever it is. Then we'll say you can use your PERT then. But I haven't had many yet to overcome the pancreatic insufficiency in our SDS population. And I will say we don't do pancreatic stim testing at Michigan. It's fallen out of favor. They do it. My friends at Cincinnati do it a lot. And I've always told families the reason is because a place like Cincinnati will do it. It's the same person doing it, same lab, same tech, same everything. And you have to do it just right every single time, because otherwise, if you're not doing it repetitively and you're not doing it the right way every time, it's an absolutely useless test. But my friends at Cincinnati will tell you no. But I just don't think it's valuable for the SDS population, because I already know if they've developed insufficiency, then we know their pancreatic function is abnormal and it will always be abnormal. However, their insufficiency can improve to the point where they can be off of enzyme replacement. Just don't know why. And I think it's hard to find out why without doing very invasive testing, such as EUS with FNA, which we do here at Michigan, and sampling the pancreas, which I don't want to put children through. I think it's a little excessive to try to figure that out. But hopefully one day we can figure out some sort of testing. And we don't repeat imaging, so the fatty replacement is almost always still there when we've re-imaged for something else, let's say, which is why we don't bother re-imaging, because we know it's going to sort of be permanent.
Great, thanks. And just one clarification, just so I got it clear on your talk. So when you follow your fecal elastase, I think your talk said it's independent of diet, and the test is they can be on PERT therapy and it doesn't impact the
Correct.
Correct. Okay, thanks.
That's exactly right. Old school therapy would be the current and all brands. It's all comers now. Old brands and old sort of preparations. You used to have to stop therapy to do a fecal elastase. That's no longer the case. The tricky part is you have to just reinforce with all the families that the stool has to be as formed as possible, preferably a formed piece of stool. So if they happen to have alternating bowel patterns or consistencies, and you happen to have a mushy poop, wash out the hat, throw it away, and redo it with, or a diaper, redo it with a solid piece. Now, the tricky part is they have steatorrhea. When are you ever going to get a solid piece? However, that's the whole idea, is when we're repeating it, you would hope that they have formed poop now that they're on PERT. So that's the one caveat is it does have to be a formed piece of poop to get the best result. Otherwise, you can eat all the fat or go no fat. You can do your PERT, not PERT, and you'll still get an accurate elastase.
Awesome. Thanks, Dr. Zacur. We have another question that came in. What is your procedure for genetic testing in suspected SDS cases, especially in relation to the challenges with the SDS pseudogene? In cases without a molecular diagnosis with suggestive clinical symptoms, how do you approach sibling screening?
I mean, I could start, and then I don't know, Cass, if you want to comment too, but I think the most important thing to do is to think about it, to have SDS, SBDS gene as something that's on your list of things you want to interrogate, and then to understand the test that you are sending. And so there are some commercially available labs that will say that they include SBDS on the panel, where what they're really doing is maybe they have a genome backbone or an exome backbone, and they are looking for variants that, if they did map to the SBDS gene, might be pathogenic. And then maybe they follow that up with some kind of like Sanger-based or other sequencing. Some places just will not be able to do the follow-up testing, and so they do not have SBDS on the panel. So for example, in some places like Blueprint, which I think many of us have had some issues sending to in more recent times, they actually spiked in different probes or specialized probes to their original library prep to allow for better coverage of SBDS. And then some places, for example, here at CHOP, you can do long read sequencing so that you know your mapping. And that's something we just launched a couple of months ago. And so I think the most important thing is that if you are wanting to send that test, just make sure that if you're doing panel-based testing, that it is on your panel. If you are, and then what exactly is on your panel. And so I could say, for example, here at CHOP, before we had long read PCR, we said SBDS was on our panel, but really what that meant was there were the 4 most common variants that we were able to detect. And so what we could report out was really that we felt those 4 variants were, when we had an NGS-based test, that those 4 variants were not present. And that doesn't mean that we are really interrogating the whole gene.
Yeah, I will just echo exactly what Julia said. Is it's important to know that, the not only if the SBDS gene is on the test that you're sending, but sort of exactly the methodology. And if you're highly suspicious in a patient, be persistent, because looking at different methods of analysis can be helpful. The SDS registry is always willing to, for patients that are interested in sort of research-based testing, doing more extensive research-based genetic analysis. We've identified some tiny micro deletions that are really hard to find in patients who are with a highly suspicious phenotype as their sort of second SDS mutation. So especially in those patients that have one mutation, but a very suspicious phenotype. That's kind of where I would go. This sort of, for siblings, that's a bit challenging. If you can't identify in the proband, I'm not sure how far along you can go with sibling testing. The other thing I would just say is, while I love Shwachman-Diamond syndrome, patients don't read the textbook, and in multiple of the other inherited marrow failure disorders, there are patients hiding who have classic SDS phenotypes, but genetic mutations in other disease genes. So, for example, the DBA registry identified patients with classic DBA phenotype who actually are SBDS patients. So just highlighting the importance too of being a bit more agnostic in your genetic evaluation, because sometimes the patients are a bit more tricky than we would like.
So I guess I have a follow-up question to that. So how much can we talked a lot about kind of the molecular, diagnosis of these patients. So how do you manage patients who have a very, as you mentioned, they have a very stark clinical phenotype consistent with SDS, but maybe only have a single pathogenic variant or maybe none in the SPDS gene. And do you use kind of the same surveillance techniques and management that you do for those patients, or do you feel like they're a different category?
Question and a really challenging clinical scenario. So, really that's where I tend to engage in a lot of shared decision making with families. Depending on when you came to your diagnosis of Shwachman-Diamond syndrome, sort of along this journey, patients have different thresholds of anxiety relative to malignant transformation risk. And to my knowledge, we've not had a genetically undefined patient with SDS phenotype transform in the registry, at least. But that doesn't necessarily mean that that's impossible, because hidden historically in that population were SRP54 patients, DNA-JC21 patients who we know now have a risk of transformation. So sort of having that conversation with families about rate of surveillance or type of surveillance, I think, versus known or unknown risks is important. And so that's really what I do in my practice, is sort of discuss with them, make recommendations, and kind of try to meet in the middle.
We had another question that came in regarding neutropenia. So maybe Dr. Warren, can you talk a little bit about how you decide to place patients on GCSF? And if they're not, can you talk a little bit about antibiotic prophylaxis?
Yeah, so who should get treated with GCSF, I think really depends so much on the clinical context. So I know we're here talking about SDS, and so just to touch on that for a second, I know that there can be different opinions about who should be treated with GCSF, but I really think we're not treating a number for these patients. We're treating their symptoms and their clinical course. And so we don't always have to be reaching for GCSF. We should really be doing this on a very individualized patient basis in SDS because, in part, I think because of their their malignancy risk. But I also think that we've all probably taken care of patients, including with SDS, who maybe weren't on GCSF and get an infection. And then there can be this extreme hesitancy of, well, they're actively infected and they're neutropenic, but is it sort of allowed to give GCSF? And I think you just have to assess the clinical moment in front of you. What are the risks and benefits? And even there are times where you may say, I'm going to support somebody through an infection, and I'm going to do a course of GCSF. And as they recover from that infection, maybe that's something they don't have to continue doing. When it comes to something like Elaine mutated SCN, I think most people would agree that their patients need support with GCSF. If you just look at what did our patients with Elaine SCN, for example, used to die of sepsis. And since we've started treating those patients with GCSF, we're seeing that much less. I think that the decision to use GCSF in other patients is really individualized. For those of us who've cared for Cohen syndrome patients, for example, you may care for a patient with ANCs in the 300 to 400 to 500 range who are like totally fine, who are not having any symptoms at all, who don't have oral ulcers, are not getting infected. And so even though that might feel like an uncomfortable number, that patient really may not need to be treated. And especially if you meet a patient like that whose ANC may go up a little bit when they do meet an infectious stressor. And so I think there's a lot more gray zone when it comes to the use of GCSF even in some genetically defined neutropenia syndromes. And like Elaine SCN is maybe more straightforward, and not the rest, but many other mutations are just not as clear cut. And then just to touch very briefly, I'm a second and third opinion for a lot of patients who wind up having immune neutropenia. And I've seen a lot of kids who have really suffered with neutropenia related symptoms for several years who have not been offered treatment with GCSF, because I think there's a feeling out there like GCSF is for congenital neutropenia. It's not for immune neutropenia. And so I just really would highlight that, again, we're treating the patient in front of us. And if that patient is suffering from recurrent oral ulcers or having infections, I would not withhold GCSF for a patient, even if you think that their underlying diagnosis is immune neutropenia. And then as far as antibiotic prophylaxis, I don't know that that's necessarily indicated for most of the patients that we're caring for.
Thank you. It looks like there's another question that came in. Any tips for helping adult SDS patients who were originally diagnosed clinically get access to genetic testing?
I'm just wondering if this is a question relative to insurance cost or more somebody to order the test itself. I think a PCP could certainly order a genetic test if they were comfortable doing so and could be guided by a referring hematologist, including a pediatric hematologist. I've done it many times myself, or a referral to genetics. And many genetic programs, even at pediatric hospitals, will see adult patients specifically for that reason, to improve access to genetic testing of pediatric diseases, of historically pediatric diseases.
And I don't know, Cass or Jim or other people on the call, your center's approach as well, but here at CHOP, even though typically, you know, we're seeing patients in our programs through something like established patients in our programs through something like age 21 to 25, depending on the individual situation. If there is a rare disease context, we are able to see patients above those age groups, even as new visits. And sometimes the way that winds up working is that we do sort of a one-time consultation to provide our sort of niche expertise. So I saw a 55-year-old in clinic yesterday, for example, and will not continue to care for that patient. But one of the things that we helped to do at that visit was actually to help facilitate genetic testing. And so there may be opportunities for patients diagnosed as adults to, again, meet somebody where maybe the expertise has historically been living in a pediatric center. Of course, that varies from center to center, but I could say at least here and where I was previously, we were certainly able to see adults, even just to kind of provide a one-time or rare visits in partnership with adult hematologist.
Yeah, Julia, that's a great point. I think most pediatric centers would have that ability. We certainly do here in Cincinnati, and often partner with an adult hematologist moving forward, so that there is a connection if, you know, something changes and additional expertise is needed. Maybe you don't need to see that 55-year-old again, but you can converse with their treating physician and provide the expertise in consultation. I think that's an important thing as more of our patients are growing into adulthood, which is great.
Yeah, if I'm allowed to make a comment, yeah, I agree as well. I think it's a really difficult question because I think we're understanding that, you know, in pediatrics, we're very comfortable with genetic testing. You know, we kind of have, you know, I guess a stronger spider sense for detecting genetic disorders because they're often going to appear in kids. But, you know, 30 years ago, people weren't doing genetic testing. So how many adults are living with this with maybe milder phenotypes and are undiagnosed? And so, you know, I think, you know, part of it is education, which is hard because of all the competing interests, particularly our adult colleagues have, and maybe not be able to focus on rare diseases. I know there's been some success in adding, you know, certain genes to, you know, these panels. You know, I think it was outlined the difficulties with SBDS and adding those to the panels. But, you know, I think adults are getting more broader panels, even though they may not identify, you know, this patient may have Shwachman, they have neutropenia. And so sometimes that can be a trigger as well. So I think if we can improve SBDS genetic sequencing along with the other SBDS like genes that Cass mentioned, adding those to the panels, which I know, you know, Esther and your group and others have tried to, you know, really provide education across the spectrum to try to improve the diagnosis. But yeah, I agree. I think getting it recognized in adults who are going to be seen by adult providers who might have milder phenotypes, you know, can be difficult. I'll add too that we've had a couple diagnoses as well where, you know, as Cass pointed out, they have these benign somatic changes like the del20q or the isochrome 7q, and sometimes that pops up in a workup for neutropenia, and that can trigger it as well. But again, that does require having the knowledge base to know that that's associated with, you know, patients who have Shwachman-Diamond, and, you know, adults are kind of taught if there's any abnormality in chromosome 7, that's going to is often a bad finding, which is true. But having that knowledge of that there are not just clinical phenotypes but molecular phenotypes that are common. But yeah, I'm kind of speaking to things that I know you're aware of, but I think it's really hard to do this. But again, it's great that we're getting more education out. I think ASH has been putting more focus on these rare disorders and getting more adults to those. And so I think all of us are working hard to spread that education and understanding that this is not just a pediatric disorder.
Awesome. We'll keep the questions coming. I have a question. So while we're waiting on some more, this is for Dr. Warren. So as a hematologist, I find it, particularly difficult to start the workup in a kid that, I don't have a ton of suspicion for cyclic neutropenia, or I'm not exactly sure what's going on. So kind of committing the patient, a pediatric patient, to 3 to 4 time week CBCs, I think is kind of hard sell. Do you ever start with genetic testing first? And if you have genetic testing, kind of skip that process, or how do you approach that?
Yeah, so I think maybe a couple parts to that. We are generally moving towards using genetic testing earlier and earlier for patients for whom we are concerned about the phenotype that they have. So, I think if you are meeting a kid who is having recurrent infections, oral manifestations, poor growth, you have a high suspicion that they have some kind of, genetic based neutropenic disorder. I think moving towards sending genetic testing earlier can be helpful to you. And the challenge is just, let's say you have, an Elaine mutation, for example, come back. You may not necessarily know for sure what is their phenotype, right? Are they an SCN patient or a cyclic patient just based on their genetic test? And even the same exact nucleotide change can express as SCN or cyclic neutropenia and can express differently even within the same family. And so, I think understanding what the phenotype is still important. And sometimes it'll be so obvious when you're talking to a family and they'll use those phrases with you, like, I could set my watch by when my kid is going to feel sick again. Or, I started taking a notes and I thought I was going crazy, but they seemed like it was almost like clockwork. Every 4 weeks, they just felt terrible. And then they seemed fine in between. So for patients who you really are getting this history that is concerning to you, then I think, you might do these things in parallel, right? You might even send genetic testing, and as you're waiting for it, start those frequent CBC checks. If you talk to people who have decades of experience working up these patients, like through the SCNIR and hearing about other people's evaluations, you'll hear from them that even patients who may truly have a cyclic neutropenia phenotype, that cycle may not be the classic textbook 21 to 35 days with 3 to 7 days of nadir under the age of 3. And that those cycles may be more irregular in early infancy. So the nadir period may be longer, the length between cycles may be a little less totally predictable under age 3. And so if you have a patient, now let's say you do have a patient with an Elaine mutation, for example, and you're managing their GCSF, and you maybe checked some repetitive CBCs, and over the course of a couple weeks, they were persistently low, and you thought, well, this patient has congenital neutropenia. And then as you treat with GCSF, you just have these random times that you're kind of checking random ANCs, and it's 18,000 or 15,000, and you're wondering if your GCSF dose is wrong. That may be, and then you check it again and it's 1,500. That may be a patient that when they're over the age of 3, you come back and you try that sort of clustered CBC approach again to see if they really do have a cyclic neutropenia phenotype. And then you could also say, well, does it even matter? And so again, I think there's some emerging data here, but at least in the US SCNIR, the rate of malignant transformation appears to be extremely low in cyclic neutropenia expression as opposed to SCN. And so, is it possible in the future that cyclic neutropenia patients may not require bone marrow surveillance, whereas that may be something we'd still want to do for SCN patients? I think it's quite tricky. I would say if you have a kiddo who's, 18 months old and had an incidentally identified low ANC and is clinically so well and does not have a concerning history, I do not think that 3 times a week CBCs needs to be a part of your evaluation for every child you're meeting with neutropenia. And then I would take like 5 seconds to stand on the antigranulocyte antibody soapbox and say would include that for patients who are antigranulocyte antibody negative. So this is one of the common things that I see is a kid who's like totally fine and had this incidentally identified ANC of 0 and is completely asymptomatic. And their parents are saying words to you like, I never would have known that anything was wrong with them if we hadn't gotten this lab. And, in retrospect, somebody who ordered that really just wanted the hemoglobin, but didn't uncheck the differential, right? And that's the child that's in front of you. And the antigranulocyte antibody test is negative. That negative test doesn't mean that you are not dealing with immune neutropenia of childhood, because that test does have a low sensitivity. So again, that child, I don't think you have to commit to 3 times a week CBCs if they're just clinically very well. And then, sorry, very last thing is it's not only Elaine that can have a cyclic neutropenia presentation. Some other genotypes have been described very rarely to have some cycling pattern to them. And then we estimate something like 5% of patients with a cyclic neutropenia phenotype appear to be not to have a genetically defined lesion. And so just because your genetic testing is negative doesn't mean it isn't cyclic neutropenia.
Thank you. That was super helpful.
Okay, reminder, we're on for another 50 minutes or so, so please put your questions in the Q&A. Again, access to these 3 experts would normally cost you thousands of dollars. So this is your time to put in good questions. I had a question, we even have some difference of opinions at my center here at Vanderbilt. So I'm curious what Cass and Julia think about how often should we be sending, red cell phenotyping for the Duffy antigen in the work of neutropenia? Because I almost see it, Julia, as, you talked a lot about the pitfalls of antibody testing, but I wonder if we're going to run into the same issue with this, right? That it might be a patient who's Duffy null, but may have also a concurrent, other congenital neutrophil problem, and we're going to dismiss it because the testing was positive for Duffy null. And so I'm curious how in your practice or others who are on the panel, how they incorporate, kind of the Duffy testing in their clinical practice.
What a great question. We recently, maybe I want to say maybe a year or 2 ago, changed something in the computer that made it easier to order Duffy testing, and also started having more conversations as a group about our patients who are kids who were being referred to us for ANCs of like 900 or 1,000 and getting a lot of workup. And was there a way for some of these kids to, update our terminology, first of all, which is very important to do. And then additionally, to provide that evidence that could help us say, look, we're really not worried about this child. This child's normal. I think 2 major challenges is under the age of 3. And I kind of can't counsel families on this, like how low can you go, Duffy null? What is a Duffy null normal range under the age of 3? And so, for example, I just saw a patient with Fanconi anemia who is, I don't know, 10 months old. And we are, checking CBCs. He's kind of getting set up in our program and is also Duffy null. And ANC on 1 check a little while ago was 500, and then it was just 400. And so all the other counts are 100% normal. And so is that this 10-month-old's normal ANC and no symptoms at all? And so how interested do we need to be in that ANC for a Fanconi patient who's also Duffy null, who was found obviously not based on their counts, but based on other phenotypic features that led to the diagnosis of Fanconi. Yes, I think this is right now, as we now have easier access to it. What I see in my own colleagues is that there is not a lot of, I'm just going to call this Duffy, there's more leaning in the direction of it's Duffy, but it's so low. Is it Duffy, or do I feel really worried about this ANC? And so I think people are at least leaning in what I would consider to be the more appropriate direction. I do think based on now the many, many children we have sent this testing on, I do, and I'm very interested to see there's this formal testing that's being sort of coordinated through ASH to try to answer this question. I would not be surprised if we wind up learning that Duffy null patients at 6 months of age may have ANCs as low as 300 to 500. I just based on sort of what we have been seeing clinically, and I know that some others have suggested as well. That's really challenging because that's in the range of some of the inherited disorders that we would worry about. And I do think until we really have compelling data that can say that might be this child's normal, that those are kids we probably need to do a few more evaluations on and need to maybe follow for a little bit longer until we know more. I will say the kids where I've seen ANCs that low have absolutely no symptoms at all and are doing extremely well. And when they get sick, their ANC goes up. So it could be another opportunity for even looking at things like steroid mobilization tests in some of those populations to just try to understand what you're working with. But it's a favorite topic and a really big challenge right now. I don't know, Cass, if you have any other thoughts, or Jim, what you guys are doing.
I mean, I think you hit the nail on the head. It is an area of challenge with a paucity of data that we need to work on to help us guide our things better. I am sort of in the camp of if I'm worried about an ANC, I definitely evaluate a little bit more probably than a little bit less and follow patients, as you say, to try to look at a bit of a pattern, especially in the younger age groups. But I do think it's a great question that would be nice to answer in a collaborative group. Yeah.
Yeah, thanks. That's helpful. I really like the, I think both of you said it's a lot of it's the clinical phenotype, right? The Duffy null are going to look great. It's not a disease. It's a neutrophil count. And so I think that helps to drive it. So I think there's variability in our practice. We talk about this all the time. And I think certainly it doesn't stop us from doing more workup. As both of you had said, if the patient has a clinical phenotype that's not consistent with that. I agree, Julia, it'd be nice if we can get better norms for that across the ages. So hopefully that will develop over time. But sometimes I've gotten it because, this kid keeps on going to the ER and getting works up for fevers and maybe even admitted, and to maybe, again, not necessarily that rules out other causes, but at least gives us, instead of having to put this poor child through expensive testing, frequent ER visits, at least usually in those situations, I'll send it just so at least we have an answer for the lower neutrophil count, and assuming that there's something else in the phenotype that would make me more concerned, then I'm a little bit more comfortable accounting for the lower neutrophil count based on that test.
We just had these back-to-back patients, though, that brings up this issue really well, who both needed to have, it was kind of uncanny, like inguinal hernia repair. And the team honestly wanted to make sure the hemoglobin and platelets were okay pre-op, but didn't uncheck the diff. And so we had these 2 3-month-olds. There is only 3 months worth of data in their life, right? And I don't think anybody would say that that's long enough to know that that child does not have a history of frequent invasive or serious infections. And they had both of them ANCs in the 300s. And then again, just part of sort of, we have been ordering Duffy testing more routinely, even if it's to be able to say, if there's something like immune neutropenia, what number might you recover to, right? Or if we're working you up for some other cause. So here we are stuck with 2 kids who need to have a surgery that you may want the ANC to be higher for. And we only have 3 months worth of data on them, an ANC of like 310 or 320. What do you do for that patient? Although this might seem like a really niche and random situation to be in, I think that things like this may only continue to come up, especially as, for whatever reason, we see so many people ordering CBCs with diffs for pre-op evaluation in otherwise healthy kids. And so honestly, they wound up getting, very short GCSF dosing pre-op because there was so much concern about how low that ANC was. And we were really trying to strike that balance between getting them to a surgery that our surgeons felt like needed to happen on a short time frame, but not quite being comfortable saying, oh, that's just Duffy. And again, I hope we'll be able to answer that question soon.
Seems like we have some other questions coming in. I guess while we're on this topic, can we talk a little bit about the steroid mobilization test and if there's any other lab-based evaluations that can reflect neutrophil mobilization?
Yeah, well, I don't want to start a fight or anything, but I don't love I don't love anti-granulocyte antibody testing. I think, first of all, one issue is that many people order the screen test, which can't tell the difference between antibodies that are specific to neutrophils and antibodies that are HLA class 1. Then some people will order the appropriate reflex testing, but again, the sensitivity and specificity are not great on those. There's now at least 2 cohorts that I'm aware of where patients with genetically defined SCN have been observed up 20 to 25% of them to have positive anti-granulocyte antibody testing. And this is done historically, and it's not really clear from some of this data if that was screen tested versus confirmatory testing. But I certainly have personally cared for a HAX1 SCN patient who for years was having lots and lots of symptoms and was untreated because they had immune neutropenia, which was diagnosed because of a positive anti-granulocyte antibody test. So when that test came back positive, the provider caring for this kid did not send genetic testing, didn't do a marrow, and said, that's what you have and you don't need any treatment, even though by the time he came to see me, it had multiple infections and like half his teeth were falling out. So I don't love that test. I think it can lead us astray. I also think when it's negative and the child in front of us really looks a lot like immune neutropenia, we say, oh, it's just because it's not that sensitive of a test, but we still think you have immune neutropenia. The approach to the reason that you want to understand, in my opinion, if this patient has a mature neutrophil pool kind of hanging around and able to be mobilized is to try to provide some guidance, I think, to families about, does this patient need to go to the emergency room for fevers? And I say that as somebody who's seeing a lot of these children as a second or third opinion, children who have been actually managed as needing to follow fever precautions for many years, and that really negatively impacting the family and the child. And so I think those of us who see these patients, we've heard a lot of stories from families like, well, I stopped going to kids' birthday parties because it just wasn't worth it. Like some kid there is going to have a sniffly nose, and then my kid's going to pick that up and they're going to have a 101.5 and I have to go to the emergency room. And so families really start to withdraw. I see this quite a lot. Most of my clinic is neutropenia and families just coming in and kind of describing how much they have restricted their lives so that they don't encounter something that will cause their child to have a fever and then they have to go to the ER. And so what I think can help with the steroid mobilization challenge, especially for a child whose clinical history is so reassuring to you, and you're trying to provide that next level of reassurance to a family or maybe to their treating team to say, hey, this kid's never actually had a documented severe infection. They're doing extremely well. They're growing. They're not having oral manifestations. Is there one more thing that we can do that can just help everybody say it would be okay to peel back fever precautions because they really can so negatively impact a family's life? And so the steroid mobilization test, I did not invent this. I just want to call that out. Like I learned this from Peter Newberger, and I know that he uses this quite a bit. So you draw a CBC and right away you give a dose of prednisone or prednisolone 1 to 2 milligrams per kilo, just one dose. And then 4 to 6 hours later, you check another CBC and it should double. The ANC should double. And that I think can help you feel reassured without having to do a bone marrow biopsy that this kid has mobilizable mature neutrophils sitting in some reservoir, whichever reservoir that is. to me, this is like a modified form of the skin window test, which we would never do nowadays, but there's some nice studies from the 70s where they ripped off a piece of people's skin and then stuck a glass slide there every hour for 8 hours and then looked again at 16 and 24 hours. And you can tell the difference between people who have immune neutropenia because right away within that first time point, that area of injury is filled with mature neutrophils. And then they kind of recede within 24 hours. And so this is like a non-invasive, I think, ethical way to sort of try and get at a same mimic of that type of a stress and just say, is there a way that you can signal to wherever these pools are living to have more cells out into the periphery? But again, I don't know that you always need to do it. If you're meeting this child for the first time and everything about the child that you're seeing screams immune neutropenia to you, and they're extremely well and they're growing, they have no oral manifestations, and they're doing super great, I think you might be able to say you don't have to follow fever precautions. One other approach that I think some of my colleagues adopt is to say, when I meet a kid like that, I tell the families I want them to follow fever precautions and let's try to document when ill arise in the ANC. And so I know that's an approach that some people take as well. And they'll say, hey, that ear infection that you get where you're getting prescribed amoxicillin, grab a CBC at the same time. And if that's suddenly, way up, then we can feel positive that you have a mobilizable pool and you don't have to keep following fever precautions. So that's like another approach. And I think all those forms are valid and depend on your and the family's comfort level. I do, sorry, last thing. I say do always tell families if they're not following fever precautions. That does not mean don't seek care if you think your child looks ill. And I always really try to emphasize that. If you don't like the way your child is looking, go to the emergency room. Follow your general pediatrician's guidelines because kids can still get regular kid illnesses. For example, if they have an unexplained fever for over 3 days, they may need a urinalysis. They may need to have their ears checked, for example. So I always like to stress with families that if you ever think your child looks ill, seek urgent care. If you have a child that has a fever for more than 3 to 4 days, follow your general pediatrician's guidance on fever approach. Jim, did you publish that study that you had presented before about looking at?
Soon, yes. Yeah. So Joe's referring to we got more patients, so we were kind of reanalyzing the data, but it basically was to this question of patients who have benign neutropenia disorders who present with fevers and kind of the management for that. The risk of infection was, as you would expect, is pretty similar to other patients who come to the ED with fever. And if they had a invasive infection, they look like it. So it was we weren't really finding occult infections. But what we did identify is a large surplus of healthcare resources which were used on these patients. Lots of admissions, lots of IV antibiotics, because again, a lot of these are handled by hematology oncology physicians who are used to managing, oncology neutropenia, which is, to Julia's point, that is a transient form of, no neutrophil reserves. So handled much differently, for sure. So I think getting that data will help and understanding more just what the infection risk is. And I want to point out a really important fact of many that were in Julia's talk is it's great for your sites if you document a fever plan in your patients. So you see them and you have your assessment and plan for them, but include that in there. And so we worked in a QI project at our center for every non-oncologic neutropenia patient that we see, we put in a plan because again, these patients are coming in the middle of the night. It's going to be a fellow who may not know this disorder very well, and not know exactly what your brain's thinking. And those are hard to send a patient home if you don't know them with neutropenia. I totally get that. And so we can be a great service for our colleagues who are managing these patients on the weekends or overnight by kind of explaining what you should do for fever, with the caveat, as Julia said, if they look ill, then it's a different story. And I think since doing that, we haven't gone back and looked at to see if that had a major impact on that. We would expect it would, but that data hasn't been collected yet.
Jim, I think that's so fantastic that you're doing that. And this is relevant to our patients with SDS as well. Other inherited bone marrow failure syndromes. I think people don't know what to do if these patients have a fever, and we see all kinds of management happening. I think this is challenging in our SDS patients as well, because maybe they live with an ANC of like 450. And historically, and I'm interested in what other centers are doing. Historically, our oncology colleagues used 500 as an ANC cutoff for what would require an admission, essentially. I think from an oncology standpoint, and I'm just going to exclude BMT for a second. From an oncology standpoint, at least here at our center, we actually now have adopted a risk stratification protocol where most of the settings where you have to come in is now ANCs under 200, and that some fever neutropenia episodes can be categorized as low risk, even if the ANC is in that 200 to 500 range, and be managed on an outpatient basis and do not require admission. And even if the patient has an ANC within the last 24 hours and spikes of fever, and that ANC was between 200 to 500, there are some pathways you can go down where you may not even need to come in. But I think that has not, and we're two separate divisions here at CHOP. I think that has not carried over to our hematology team. And so we have a pretty wide array of approaches to a hematology-based patient with fever and neutropenia. And this is especially difficult for our immune neutropenia patients and our patients with things like Shwachman, who may have those ANCs right in that range, where they're doing well, they're not on G-CSF, but they're not having frequent infections, and they're feeling well, but they had previously been advised to come in anytime they got a fever. And now their ANC is 450, and like, do they have to be admitted to the hospital? And so we're still trying a little bit to harmonize some of our own approaches, which I think probably could very reasonably land a little bit more in line with using ANCs under 200, but very interested to hear what other people are doing.
Yeah, I agree. I think that it's a heterogeneous approach across, and I think it is harder in centers like CHOP and in Cincinnati, where the divisions are also very siloed. And so what the oncology folks are doing is very different from the hematology folks and very different from the BMT folks. And in fact, for us, the inherited marrow failure, including the neutropenia syndromes, mostly live in BMT, but occasionally live in hematology. So there's also sort of that challenge as well. I think taking that approach across an institution like you've done, Jim, and making sort of a uniform plan to put a plan in is a great way to start, at least. And then it's a starting point for discussion amongst the groups to sort of try to harmonize approaches and maybe liberalize, as you say, Julia, to slightly lower ANCs in those patients without a history who look good, etc.
Yeah, this is a great discussion. I would say, and I know Cass and NAPAC and others are kind of looking, trying to understand the infectious risk better, because I think, a lot of, we talk about kind of the oncology carryover, but I would say also the Elaine SCN carryover, right? I mean, they have ANCs close to 0. And so we know that they're at super high risk. But again, our Shwachman Diamond patient with an ANC of 450, I don't know, I don't think we know that data yet, Cass, unless you've seen it, just haven't published it yet. But it'd be great, right? Because I think, this is a lifelong disorder, and certainly quality of life is really important. And coming into the ED, once a month for fever and blood cultures and all those things are really impactful for patient care. All right, I have a question for George. So it's a two-parter question. So one, I've had a patient or two where the family kind of gives therapy as on a PRN basis. Maybe it's the diet they have, or they just kind of follow the stools. So I wanted your comment on that. Do you feel if that's a good approach or not? Knowing that this is a chronic disorder, and perhaps if you're under treating the enzyme deficiency, it might have long-term consequences for growth and development. And then my second question is vitamin replacement. How aggressive do we need to do for that? particularly if their stools normalize? And how often do you check vitamin levels to ascertain that they are getting the appropriate amount of absorption?
Great questions. I don't generally recommend the PRN or as needed PERT. I think you could probably get away with it for some patients who are willing to live with a little bit of, some symptoms, maybe some bloating, some belly pain, nausea, even some steatorrhea. I don't recommend it. I definitely recommend against that in the younger age groups who are still in the growing phases of life. Most patients, I guess I don't want to generalize, but I would say most of my patients, they get so used to it that by the time they're adolescents, they know they're supposed to be taking it to at least not have symptoms, even if they are, growing just fine. So I don't generally recommend that. And as a segue to the vitamin absorption and fat soluble vitamin deficiencies, I check every year, no matter what. If any of the vitamins are low, we supplement, and we also readjust PERT. We don't just supplement. So we'll check and we'll supplement, but we'll readjust PERT if we need to because something's obviously off, or maybe they've outgrown the dose. And as I mentioned in my talk, the patient where the family, the child's growing really well and they want to outgrow the dose. That's fine. We're going to try that, but they can obviously run the risk of having a vitamin deficiency. And the most common one we see, especially here in Michigan, obviously because of sunshine, also is vitamin D deficiency. But so we're supplementing that almost anyway. But I will still reassess with my dietitian their enzyme replacement to make sure that's not the cause, or just making sure that we're are you taking it every time? Do you miss here and there? And we have ways of asking, similarly to the way we ask for medicines that they're supposed to take for other GI conditions. How many times did you miss last week? Rather than saying, do you take it every time? And sometimes those nuanced questions will get a result like, yeah, I sort of didn't take it with the hamburger I ate, or we went to a pizza party and we forgot it. But I generally recommend to most of these patients, once we start it, you stay on it. And for those who we do find trouble with growth or vitamin deficiencies or persistent symptoms, I will push the dose a little bit to make sure that it's not an adherence issue, or ensure that it's not an adherence issue, and then push the dose if we have to get better symptom control, enzyme replacement, or symptom control, symptom and growth control, as well as deficiencies. But most of my patients will, once we put them on it, they stay on it for the most part. And I don't have to usually go as far as replacing for carbs or replacing for protein. It's mainly fat. I have a couple of families who choose to they will dose based on fat calculation, which their parents are engineers. Nothing against engineers, but they want to do it that way rather than overdose or underdose per meal. But usually most of my patients will figure out over time, like, I have almost the same breakfast on Fridays, or, we have our weekend pancakes, or, dad makes sunny side up eggs on Saturdays, which is what I do. So, we know that they need an extra capsule or an extra dose for these things because they're just so used to it by that point. So they get it. And it's like, a handful of goldfish, crackers, whatever, I can get away with just doing one instead of two or something like that. So they usually figure it out.
Thanks. And just one quick follow-up question for the
Mhm.
panel. Do we have much knowledge, or is there, maybe some developing effort to get Shwachman diamond specific growth curves because I think, to your point, obviously I think following the trajectory is important, but how do we know if they're really falling off for a Shwachman diamond patient, or this is kind of, patients with Shwachman diamond often have short statures. So kind of is there some effort to understand that better?
So actually, thanks for the plug. We just published the registry's growth curves in the last couple months. There was an effort from the Italian registry a few years back, and then we sort of looked at it from an American population lens, and that was just published. Generally speaking, patients are obviously much shorter and smaller, but do sort of tend to
start to enter the bottom of the normal growth curve with time. But those are available online. Yeah.
Awesome. Dr. Myers, I think we have another question for you. What's your current practice and treatment of MDS, AML, and SDS? Do you try to achieve CR or remission before going into transplant, or do you just go to allotransplant? Is there any data to support your selection? What are your thoughts on GVL and donor selection? Do you preference PBSC over BM or avoid MSD when reasonably higher GVL donor options are available?
Great questions.
Yeah, great question.
From a transplanter, I'm sure. I'll tackle the first part first. I don't try to achieve CR, and the data for that is from the paper, the Lancet Hematology paper from a few years back, that looked at outcomes of patients with MDS and AML with Shwachman-Diamond syndrome. And patients who received high-dose chemotherapy up front really did poorly, and many of them didn't make it to a transplant option due to toxicity. So, and there are some survivors of patients, anecdotally, who have gone in with low-level disease and survived. So the caveat to that would be, as I'm getting them ready for transplant, I don't just usually let them sit with no therapy at all. Often we'll try a combination of azacitidine plus or minus venetoclax, which has given some cytoreduction in preparation for transplant, but I wouldn't delay waiting for a marrow and CR to move forward once the donor is identified and you're ready to go. As far as donor selection and GVL, that's a hard question. I don't believe I've ever had the chance to decline matched sibling donor in favor of an unrelated donor in the setting of MDS or AML. I'm not historically, patients who've had GVH post-transplant, it hasn't helped them with their malignancy. And so I'm not sure that I would err on the side of mismatch, but potentially the use of an unrelated donor could be considered. I do tend towards PBSC in that setting, just for that reason, to try to give a little bit more opportunity for GVL in a minimal sense, and to give a very good cell dose, because oftentimes you'll get a more robust immune reconstitution with a higher cell dose. And so the faster you get immune reconstitution, the faster, in theory, those cells are there to work on residual leukemia disease. Also, additionally, in patients who do have MRD negativity or even low-level MRD post-transplant, I have used post-transplant azacitidine with good effect, at least temporarily. I have anecdotally a couple of patients that have done well long-term with post-transplant azacitidine plus or minus a targeted agent like ruxolitinib, if their disease is amenable to that. That last case wasn't SDS, but it was a different inherited marrow failure syndrome.
Okay, we have another question from Dr. Hars. Are there efforts to update guidelines for HEMONC to include germline genetic testing and standard workups when young adults present with AML MDS? And then she mentioned, based on the paper Dr. Myers highlighted in her presentation, that shows that a significant number of patients may have SDS or other constitutional mutations without knowing.
I think there are some guidelines out there, some of which will suggest that any patient presenting with, and depending on the guideline, but that you may consider testing under the age of 40. I think the challenge is, what is the testing? And that there's a lot of variable uptake here. And so the recommendations I think have been clear on sending germline testing. So of course, challenges there being, what's the source of germline tissue as one challenge? And then do you send other evaluations routinely for inherited bone marrow failure syndromes, for example, breakage studies? Again, what's the source of the tissue for that? And telomere length analysis. And then as an additional challenge for SDS, what panel are you sending, and does it have SPDS on it? And I think there is, even though I think we are seeing more uptake in adult centers to test for inherited marrow failure syndromes, that awareness that there are panels that are being chosen may not have SPDS included, that that awareness probably has room to improve. And then approach to sending functional tests as available probably also has room to improve. And I think that's especially relevant in some of the disorders where we know there can be somatic reversion or other somatic genetic rescue events that happen in the hematopoietic compartment that can impact your testing, especially when using a not a truly germline source for your testing. We actually, if it's like helpful to hear, have a hematologic malignancy predisposition working group where we meet CHOP and PEN physicians who are interested in this disease population once a month and review cases. And so I think there's been, I know for sure the physicians who are kind of leading some of this effort are trying so hard to capture all of the AML MDS patients that come in on the adult side, to see them while they're inpatient and to offer germline testing. The problem that we can't quite relate to as pediatricians is just the sheer volume of patients that looks like on the adult side, because there's just so much more of this disease burden that they encounter. And then I think a really interesting age group is, what about 40 to 50? And so how many patients are going to be in that, really going to be actually be in that age range? And especially if you see somebody who's coming in with TP53 mutated MDS or AML or complex karyotype, or have other findings that might sort of pique your curiosity. So I know our colleagues across the way actually diagnosed I believe, 63-year-old with Fanconi anemia. And so it can happen, and it should be on sort of something that people are thinking about. And the really key issues that we wind up talking about every time we get together are treatment regimen and anticipated toxicity and donor selection. And that's really a huge problem, because another challenge that I know our adult colleagues have more than we do is accessing genetic testing for their patients. So even if they want to send it, it can be difficult to get. It can almost impossible to send it from the inpatient setting from a test utilization hospital billing standpoint, and then sometimes very challenging to send it on an outpatient setting. And so having some guidelines out there to support people as they are trying to pursue that testing, I think has, in the last few years, having those guidelines published has been helpful.
Yeah, and I think it's also on us a little bit to do exactly what you guys are doing, Julia, and reach out to our adult colleagues and increase awareness, because it isn't just that the guidelines exist, somebody has to read and use them and have that conversation about what else to look for. Because it is, sometimes the referral for the 30-year-old who has a del20q mutation and is developmentally delayed with concerning, findings in the marrow makes its way to the right person, because there's been some conversations historically about that kind of scenario. So I think just engaging our adult colleagues as well is important, both for early diagnosis of previously unknown patients, but also then, obviously for the care of patients as they age.
Yeah, I'll put another potential approach to think about, for those on the call. And so we have a similar problem. This is a problem across all rare disease fields. And I think historically, some sites are really good at this, right? As Julia said, that's an awesome way that you guys are able to kind of consolidate knowledge. Obviously that's difficult because the adults are just, they just have so many patients. It's really hard for them to become experts in this area. So having that collaboration is great. But obviously that can't be done at every center. The smaller centers, the expertise shrinks even more. And so, in a lot of communities, because the ability to have these, Cass, you mentioned you could have these guidelines that are there, they're going to be maybe hard to access or don't have time to access. There's been a little bit more push to kind of, instead of trying to over-educate when you're trying to have competing interests and competing time to provide that, part of it is can we start developing more automated tools? And so, both, Cass lined out really well what kind of the typical phenotype is. Now, there's very much atypical ones, but perhaps, in time, this is going to be true for identification of a lot of rare diseases. So you have an adult AML patient who has a TP53 mutation. Again, you'd have to like decide what the sensitivity would be. But I do think that's going to be a novel way moving forward to identify not just Shwachman diamond, but a lot of rare diseases, particularly in adults who, again, just don't have the expertise that some of our pediatric colleagues do to flag certain patients. And, each site could have different ways to deal with that, identification, whether there's a working group, like they do at CHOP, or, goes directly to, Cincy to the bone marrow failure group there. I mean, there's a lot of ways that each site could handle this, but I do think, that is now that these tools can be developed, that might be a new solution to helping identify these patients. Obviously they need to be within the healthcare system to do that, but might be kind of a new strategy to find these patients. All right, can I ask a transplant question, if I may? So, Cass, I always enjoy learning from you about this really hard disease to transplant. I'm curious in the patients that you've transplanted, because I get this question all the time, and the Elaine neutropenia patients. In the non-MDS AML patients that you've transplanted, have you identified any mixed chimeras in hematopoietic cells or myeloid cells? And is there any concern that if you have mixed chimeras, is that you're still going to impart an MDS risk if that happens?
Yeah, tricky question, especially in light of the new data that suggests that there's lymphoma risk as well. I think the vast majority of patients with SDS have full myeloid chimerism post-transplant. There is not an uncommon amount of mixed chimerism, especially limited numbers now, but with the treosulfan, and that's a known issue with treosulfan-based approaches. That does seem to improve with time, so it's hard to know, and we'll have to see as those patients get further out from transplant whether or not they achieve full chimerism. But I don't routinely marrow or surveil patients other than standard post-transplant surveillance once you get further than a year post-transplant, even if you have some low-level mixed chimerism.
Yeah, Julia, I'd be curious. I know you're not a transplanter, but you think a lot about clonal hematopoiesis. So I'm curious your thoughts even if there was a small clone left behind, not clone, I should say, some residual hematopoietic cells left behind in a Shwachman patient, if you would hypothesize that could be dangerous or not.
What I think we also need to know more about is what's the contribution of the niche. So if you have hematopoietic reconstitution and you don't have the cell intrinsic stress from, if you, in the hematopoietic compartment, then how does the niche change to then provide signals that may have been supporting an environment that would itself promote or favor, or whatever, however you want to conceptualize it, the expansion of that type of a clone, right? Because I think we don't understand that very well. And I know we're talking about SDS, but I really think about this for patients who may be eligible coming up here for gene therapies for all inherited marrow failure disorders, and really think a lot about, in an Elaine patient, if they, just to say something extreme, like if they have a RONX1 mutation, should they not have gene therapy? Because now you've relieved the cell intrinsic stress from that clone, or were there some cell extrinsic, contributions to that clone having some kind of expansion or further influence on the acquisition of additional mutations? In Fanconi patients, like if they're 1Q plus already, they can't have gene therapy. I think these are questions I would love to know the answer to. And yeah, like, would you get it? Let's say we had SBDS targeted gene therapy. Would you offer it to somebody with a TP53 VAF of 1%? I'd love to know the answer to that, because, now that clone is TP53 mutated, but doesn't have a ribosome biogenesis defect, so what advantage would that clone have over time? And then would you, let's say you do gene therapy for somebody and they like the proposed approach to Fanconi gene therapy and there's no chemo, there's, you do not clear the marrow out at all first, and you just say over time, these cells are going to take over. It's almost like a similar question there. Do those patients need annual surveillance bone marrow still? I don't know.
Your point about gene therapy is absolutely right. I think, and I don't know that the answer is right across all the different
Right.
diseases either. I mean, there is one patient reported post FA gene therapy to have developed a leukemia in the non-genetically modified cells.
Correct.
And so, that sort of speaks to that sort of risk of, if the drive for stress hematopoiesis is removed, does that remove the risk of malignant transformation? And I don't think we know. For the telomere gene therapy trial that I'm the PI of, patients with concerning somatic mutations are ineligible purely for that reason, because it's an early phase trial and we don't know. But how to translate that moving forward is going to be quite challenging.
I think we're almost out of time, so I did want to thank everybody today for joining our and being a part of the Nicer Education Camp today. I wanted to thank the speakers. This has been such an awesome discussion, and even me just being a junior attending, being able to collaborate and kind of hear the speakers who are experts in the fields. This has been really wonderful. I think for everybody else, who's joined the meeting today too, reaching out and kind of asking these questions to our speakers and knowing that, there's help so that we can be discussing these complex patients as a group and a community. It looks like the CME is going to be emailed out a little bit later, so expect the CME to come in your email in about an hour. And then if nobody else has any other questions, we'll let you guys all enjoy the rest of your day.
Thanks for having us.
Of course, everyone, take care. Thanks.